Yes.
Okay. Please start.
Dr. Jwana?
Yes, sir.
Yeah, please proceed with presentation.
Yes, sir.
Next slide, Sharath.
Good evening, respected teachers and my dear colleagues. I am presenting my case on ulcer. A 70-year-old gentleman hailing from Bangalore, a retired businessman, presented with a wound over the left leg since 10 months, pain in the left leg since 6 months, and watery discharge from the wound since 4 months. He was well before 10 months when he developed a wound over the previous graft site on the left lower limb. Insidious in onset, which initially was small in size, gradually progressive over the 10 months to involve the front of the mid leg to around 8 into 5 centimeter. It was associated with on and off watery, non-foul smelling discharge from the surface of the wound and a pale tissue overgrowth over the wound area. He also developed a throbbing type of pain in the entire limb, which was aggravated on walking and relieved by painkillers. He gives a history of consuming 3 to 4 paracetamol tablets to relieve his pain. He also gives a history of previously being diagnosed as lymphedema of the left lower limb in 2003, for which he had undergone a debridement and a fifth toe disarticulation in 2003 for the infected ulcer, and had a raw area over the left lower limb almost for a year, for which he underwent regular dressings. Post that, he also underwent split skin grafting for the raw area of the left leg in 2004 and 2008 for the same. He also gives a history of inability to move the left ankle joint since 2004 after undergoing the graft. However, he does not give a history of recent trauma or any history of injury to the leg, no history of claudication pain. He is a known diabetic on OHA and insulin since 2003 on medications. He is a known hypertensive also on medications. Surgical history, as I already mentioned, he's undergone debridement and fifth toe disarticulation of the left lower limb, and also split skin graft for the same twice. He consumes mixed diet. His sleep and appetite are normal. His bowel and bladder habits are normal. He's a non-smoker and non-alcoholic. Summarizing my history, a 70-year-old gentleman, a retired businessman, known diabetic hypertensive, with no alcohol or non-smoking history, with a history of past history of lymphedema of the left lower limb, and prior surgical history of debridement, skin grafting twice, presented with a non-healing ulcer over the left leg since past 10 months, and pain in the left lower limb associated with serous discharge from the wound.
Yeah. Epso, sir, anything to say in history?
So this is as per the history, what do you think you feel that the ulcer is due to?
Sir, I feel it is a non-healing ulcer of the left lower limb, sir.
Right.
Secondary to probably his diabetic status, or could be his lymphedema of the lower limb, sir.
Okay. But
where exactly is the ulcer?
It's on the shin of the left lower limb, sir.
That area you have not described. That is why sir is asking that.
Okay, sir. It is in my examination. I'll be describing it, sir. It's about 6 centimeter from the knee joint and around 10 centimeter from the tibial tuberosity, the lower border.
So more so in the leg.
Yes, sir, in the leg.
Sister Jwana, for a
Yes,
minute, as you rightly said, the patient has edema of the leg.
Yes,
I don't think in your history you have mentioned what is the cause for this, because this has been going on for almost 10 years now.
Yes,
have
sir.
they made any effort to find out what is the cause for the lymphedema? Because, otherwise it's going to recur and recur and recur.
Yes, sir. So patient was examined in the OPD. The patient did not have the previous old records. He only had a few records pertaining to the recent investigations.
Okay, forget about the records. If you were the primary surgeon in the history, what would you think are the causes for, is this a unilateral edema or bilateral edema?
Unilateral, sir.
Okay,
Left
so
lower limb.
if you are a primary surgeon, or a physician in the OPD,
Yes, sir.
what are the causes you think produces lymphedema unilaterally, and what history would you like to ask?
History of prolonged immobilization causing DVT.
So one is DVT, okay.
Or a history of lymphedema secondary to microfilaria, sir, in endemic areas.
Okay.
Did you talk about that endemic area? Did you check about that?
No, sir, patient is from Bangalore, but he gives a history of traveling. I have not mentioned that, sir.
Okay.
Anything else, sister?
Cellulitis of the limb, left lower limb, secondary to diabetes.
So you should ask for history of all these things. Okay.
Yes.
And
yes.
what about chronic venous insufficiency?
Yes, sir. It also could be.
So what I'm trying to say, sister, whenever you have unilateral edema of the limb, you need to find out what are the causes for this, because otherwise, if you don't take care of the causes, you will end up with a recurrence and recurrence and recurrence.
Yes, sir.
Okay.
Yes, sir.
Most of the time, history is the best way to know what is the disease. So good, proper history will really give you a complete picture of the patient.
Yes, sir.
There was a bit of a confusion here. You said the amputation of the toe and
Yes, sir.
over the lower limb.
Yes, sir.
So you did not mention why was there an amputation. Was it gangrene related amputation or was it infective gangrene? I mean, that is how it started. You mixed up past history and history presenting illness. That was a bit confusing.
The history of amputation was in 2003, sir.
Correct. What was the indication for amputation?
There was edema of the lower limb and infective. There was superadded infection. That's what he was saying. The entire limb was infected. He underwent debridement along with the amputation.
So that time the patient was diabetic also.
Yes, sir.
So you didn't get the old records to know whether it was ischemia, infective, because it's a combination of three diseases according to you. One is lymphedema, the second is diabetes, third is chronic venous insufficiency, which you are even suspecting. Why did you suspect chronic venous insufficiency? You can't have
she didn't,
two.
Dr. Srivatsa, she didn't suspect. I was just inquiring. You have to ask these things in the history.
No. It's very rare to find a combination of lymphatic and venous diseases together.
Yep.
Unfortunately, this is a complex case and it's not a clear-cut single disease entity situation. Very unlikely to be kept as a single undergraduate or even postgraduate case. They usually localize it to being diabetic with an ulcer or lymphedema with non-healing. Having this combination is a little difficult. We can keep on debating. Please go on to the findings, sister. Examination.
Yes, sir. General physical examination. Patient is conscious, alert, oriented to time, place, and person. He had no pallor, icterus, cyanosis, clubbing, or koilonychia. His vitals, heart rate were 88 beats per minute in the right radial artery, normal in rate, rhythm, and condition of the vessel wall normal. Blood pressure being 140 by 90 millimeter mercury in the right upper limb, supine position. He maintained a room air saturation of 98%. He was afebrile and he had a BMI of 23.8 kg per meter square. This is a picture of the lower limb, the ulcer. Bilateral
Here, the
lower
diabetes is incidental, man. This has got much more other reasons to be like this. So you have to be, you'll have to add diabetes as an associated pathology or associated condition in the presence of primary disease being something else. Primary disease is not diabetes here. Okay, continue.
You call it as ulcer or you call it as non-healing wound?
Non-healing ulcer, sir.
What is the difference between ulcer and a non-healing wound?
There are different types of ulcers. One of the type is it could be non-healing one. And it's a chronic ulcer over a period of 10 years. I would think of it in terms of chronic non-healing or a callus ulcer.
How many times he has undergone surgery now?
Twice he's undergone skin grafting, sir.
Okay.
Can I
Go ahead,
continue,
sister.
sir?
Yeah, please continue. Please continue.
Yeah, please continue.
Examination of the left lower limb. Patient's the limb attitude of the limb was neutral with ankle joint and dorsiflexion. The absent fifth digit. There was diffuse edema of the other 4 digits extending up to the leg below the knee joint. On inspection, there was an ovoid ulcer of about 7 to 5 centimeter over the mid leg anterior aspect, seen about 5 centimeter below the knee joint, with margins irregular, sloping edges, floor covered with irregular pale granulation tissue. The skin surrounding the ulcer were hyperpigmented. There were patchy areas of hyperpigmentation seen over the dorsum of the foot. There were no dilated vein visible over the leg. There were previous surgical scars seen on the dorsum of the foot, and scanty serous discharge noted, which was non-foul smelling over the ulcer. On palpation, there was no calf tenderness. The peripheral pulses. Sir, I think one slide is skipped, sir. On palpation, there was no local rise of temperature, or the ulcer was non-tender. There was an ulcer of 7 to 5 centimeter on the anterior aspect of the left lower limb, with upper margin 6 centimeter from the tibial tuberosity, lower margin 10 centimeter from the lower border of the tibia. Depth of the ulcer at the center was 0.5 centimeter. Margins were ill-defined, edges were sloping, irregular pale granulation tissue found over the ulcer. The ulcer did not bleed on touch. The base of the ulcer was bone, and surrounding skin indurated. There was no local rise of temperature over the surrounding skin. There was no edema. Non-pitting pedal edema from the toes up to knee joint noted. There was no calf tenderness. Femoral and popliteal pulses were well felt. However, I could not appreciate the dorsalis pedis, anterior tibial and posterior tibial arteries because of the indurated skin. There were no palpable venous blowouts felt. The sensation over the left lower limb was intact. There was also 3 into 2 centimeter single lymph node palpable at the left inguinal region, which was non-tender. There was no local rise of temperature. It was mobile, firm in consistency. Next, sir. The movements of the joints were restricted. The distal interphalangeal and metatarsophalangeal joints, there was no flexion or extension. There was no plantar flexion at the ankle joint. Subtalar joint, there was no inversion or eversion. And knee and hip joint, complete range of movements were present. Patient had an antalgic gait due to pain. The right lower limb examination was normal. Cardiovascular system, S1 and S2 were heard. There were no murmurs. Respiratory system examination, normal vesicular breath sounds were heard. Central nervous system, there was no focal neurological deficits. My diagnosis would be non-healing ulcer of the left mid leg with the lymphedema of the left lower limb.
Right.
Okay. So your diagnosis is a non-healing ulcer with the left leg, lymphedema, the left lower limb, isn't it?
Yes, sir.
It must also give some likely cause, no? Due to what? Suspected due to what?
Secondary to or
Secondary
something.
to what?
Secondary to the lymphedema per se, sir. Non-healing ulcer secondary to lymphedema.
Now, was there a trauma?
Okay, all right.
Now, was there a trauma or something, sister?
There's no trauma, history of trauma, sir.
Or was there infection there?
Earlier,
because
sir.
lymphedema per se will not cause an ulcer.
Yes,
the lymphedema will precipitate something else as a cause for.
Yeah, that's either it's traumatic or infective. Lymphedema per se doesn't give rise to an ulcer.
maybe a post-traumatic, probably you've not taken the trivial trauma. Most often they miss out. They don't tell that. If you dig in properly, they will be able to tell that history mostly. So the trivial trauma, which is maybe the cause of the ulcer, which has been a presentation. Don't you think so, sister?
Yes, sir. Could be, sir.
So Jwana,
Yes, sir.
lymphedema is secondary to the lymphedema is secondary or primary lymphedema is here?
This condition, sir?
No.
Yeah.
What sir is asking is whether the ulcer came first or the lymphedema came first.
Lymphedema came first, sir.
And in inspection, you didn't comment on the features of chronic ischemia.
Yeah.
You said about yeah, tell me.
Discoloration of the limb was present, sir. There were hyperpigmented areas over the limb.
What does hyperpigmented area say? What do you mean? What is the inference when you say hyperpigmentation?
When you get
prolonged duration and
no, what are the features of chronic ischemia in inspection?
Loss of hair, brittle nails.
Yes.
Hollowing of the metatarsals.
I think
skin, how does
the combination
skin subcutaneous tissue?
Here it is all indurated, sir.
Yeah, that's what. In this case, it's difficult to comment on that. I would agree with that.
Yeah,
I think if there is no history of claudication,
yes,
right,
we don't go into vascular at all. Correct.
Right.
There was no history of claudication, sir.
Yeah. So you have to give that as answer.
Yeah.
Okay, sir.
But you were complaining patient was complaining of pain, no?
Yes, sir.
But you didn't qualify the pain. When does patient gets pain? How it is relieved? So then only you can say whether it's claudication pain or pain secondary to something else.
So I mentioned that patient has pain on walking and it is relieved by taking analgesics, sir.
So what does it indicate? Patient gets pain on walking means what? Do you think in terms of claudication or no?
Suggestive of that, sir, but he mentioned mostly.
No, Sister Jwana, is it pain or is it just heaviness which is describing?
He referred to it as pain, sir, but he was comfortable on examination and when he moved out of also. So
that is what, whenever you describe pain, sister, you need to qualify that whether is it a pain because of the edema or is it because of the infection or is it because of the ulcer or because of your claudication, as what Subbu was asking. You need to qualify that, otherwise it leads to all those questions.
In fact, you have to describe where is the pain.
He had generalized pain over the left lower limb, sir, and mostly
the
kind
left lower limb is a big area. Now, so you have to say whether it is around the wound, off muscle, thigh muscle.
Mostly over the wound, sir, he mentioned.
Yeah.
Yeah. So just a minute. I think we are wasting a lot of time just on this one pain. We have only half an hour to discuss. Please kindly move on to how you will evaluate and the management. Please note, sister, that pain is a very important thing. Once you use the word pain, you have to qualify it to either of four conditions. Is it a arterial type pain claudication? Is it a venous type of pain? Is it by any chance neurological pain? Or is it non-specific pain of a wound? So these are the how you classify the pains and try and help yourself to get a diagnosis. The history gives you a lot of clues on what the patient has. So interpret it correctly. Kindly move on to how you're going to examine and manage this case, please.
Okay, sir. Thank you.
Systemically, nothing found. So lymphadenopathy, is it significant lymphadenopathy because 3 centimeters, I remember?
Yes, sir.
So what is the cause for lymphedema?
Probably the chronic non-healing ulcer could be the cause for the
Which group did you mention? The group vertical or horizontal?
It's a vertical group of nodes, sir.
Vertical group. Okay. Go on.
Yeah, please carry on.
How do you manage, sister?
I'd like to investigate the patient. Basic blood investigations like CBC to know the total count and the hemoglobin of the patient. RFTs to know the renal functions, and RBS, FPS, PPPS. FPS, PPPS, and HbA1c to know the glycemic status of the patient. I would also evaluate the wound. Since there is a serous discharge, I would take a wound swab or a culture from there. And also radiological investigations. Since it's a chronic ulcer, I would like to do an X-ray of the foot and the leg and the knee joint. And also, I would like to do a Doppler, venous Doppler to know the status of the vascular venous.
Artery and venous Doppler, both you can.
Okay, sir.
The opposite limb doesn't have varicosity, right?
No, sir. There are no vascular varicosities.
Why venous Doppler? Arterial Doppler is what you would ask.
To look for deep vein thrombosis, sir.
Okay.
Okay. Yeah.
Sister, in this case, would you look for deep vein thrombosis? What are the symptoms of this patient to say has deep vein thrombosis?
Not really,
If
sir.
you're doing a Doppler, I think you should do a Doppler from the point of your venous insufficiency rather than a DVT. What are the symptoms of DVT?
He'll have pain on walking, throbbing type of pain on walking.
Does he have?
The calf. He doesn't have, sir.
No. And is this edema, this swelling, is it recent onset?
No, sir. It's a long-standing.
DVT patient will have pain on walking, is that, sister? Or is it continuous severe pain throughout day and night?
They'll have continuous pain also, sir. And it's aggravated even on walking.
There are two types of DVT. It's the chronic DVT and the acute DVT. Please do not confuse. When you have chronic DVT, many of the symptoms get reduced and you get just the presence of swelling. The patient would have compensated except on exercise. When they get up and move around, then they get pain. In acute DVT, you have continuous pains. Okay. Yeah.
Okay, going to the specific, sister. So apart from this investigation, what else you want to do?
What else you want to do? Yes.
Any specific investigations?
And also keep Dr. Srivatsa's question in mind of the lymph node also.
Yes,
that's an important finding. Yeah?
Yes, sir. I could do a wedge biopsy of the ulcer to look for any malignant change. Also a lymph node biopsy to look for any malignant change in the ulcers.
Lymph node biopsy or something simpler and better?
FNAC can be done, sir.
Why
timing of FNAC?
FNAC is of an ulcer?
Not ulcer, sir.
FNAC is the lymph node.
Of the
lymph node.
All right. Sorry. Yes.
So that would be better than a lymph node biopsy.
Yes, sir.
Isn't it so?
Yes,
right.
Sir.
It comes back to you as being non-specific. It's not indicative of anything. It's just chronic inflammatory tissues. No evidence of TB, no evidence of malignancy. How does it help you? What do you do next?
What is the next?
We are left with 5 minutes, sir. Summarize with the management.
Yeah.
Do we have any X-ray findings? I mean, available X-ray findings? X-ray of the leg?
No, sir, not of recent.
No, would you like to do an X-ray?
I have not uploaded.
You should do an X-ray to rule out osteomyelitis, isn't it?
Yes, sir. Yes, I would like to do an X-ray. You mentioned it. I would like to do an X-ray.
I think so. We are very short of time.
Yes.
Please
Yes,
complete the management. What is the next step you want to do? How you want to go about it?
think this is a very tough case.
It's a very tough case, very tough. I mean,
No, sir. Let us just give.
It turns out to be a non-specific ulcer.
Yeah, please go ahead.
Yeah.
Doppler available? Doppler, arterial Doppler.
Sir, I think so. She has come given all the findings. Sir, let us hear her manager.
No,
Sister Jwana, just to summarize, summarize now. This is a simple ulcer secondary to a lymphedema. And as I said, the wet biopsy is negative. FNS is inflammatory tissue only, nothing specific. So how would you do? What is the definitive management now?
What is the next management you talk?
So it is not diabetic ulcer, isn't it?
Are you on line, sister?
What you want to do?
I would like to wait for the cultures and also yes, it's not diabetic ulcer. I'd like to antibiotics. I'd like to start him on antibiotics based on the culture since reports, and also based on his sugars. I'd like to control his diabetic status. And
okay, coming to the specific of the wound, sister.
What will you do for the wound?
Advise him to come for frequent follow-up to avoid further infections or further progression.
Would you like to do a debridement? Would you like to do a debridement first? You should do a debridement.
Advise him for a debridement of the ulcer.
What all you want to do in the
yes, for debridement, because it's a chronic non-healing ulcer. I would like to do a debridement of the ulcer.
Are you able to hear us, Jwana?
Yeah.
The slough and the not very clear, sir.
I think somebody can summarize because of paucity of time.
I think it's
one of the examiners can summarize.
I request Epso sir to summarize.
It looks like a more of a non-specific, chronic non-specific ulcer, secondary to maybe you can consider it to
line, Jwana, can you hear us?
So best is to manage conservative management. Right now, you should do a proper debridement and then go for a later on once tissues become better, you can go for a definitive skin grafting. The skin grafting has failed twice because probably the wound was not prepared well and the grafting was done, isn't it? As I know that the Doppler studies show that all the pulsations are good and all the vessels are of good caliber, so no need to worry about the ischemic part. Just management of the wound would be good enough. I think so. That should be the end of this case. Anything else? Anybody please want to add, sir?
That's a perfect summary, Dr. Narayan. And Hepso, sir, it's very correct.
One more add-on thing, Jwana. Apart from whatever sir said, I think since edema is persistent, I think you need to make sure once the wound heals well, you need to be on a counting to make sure the edema comes down. Otherwise, this is going to recur.
Addition of any
chronic ulcer,
addition of any pump like lymphopress device help the patient, because it's a chronic lymphedema. It may not help in
nothing
for lymphedema.
Chronic lymphedema, sir. It is just we are just going to buy time. That's all. Nothing works on these chronic lymphedemas.
Thank you, sir.
One more thing I wanted to add.
Thank you, sir.
Would be the answer. And since the vascularity is good and it is over the tibia, which is shin bone, a flap is a better answer than a graft because graft has failed twice.
Will the flap hold on, sir, in this case?
Thank you, sir.
A flap would be better.
Oh, just 1 second, Harish.
Yeah.
Just 1 second. How well will a flap hold on if there are any plastic surgeons in the meeting?
No. They will not work, sir. Most often they don't work. Best is to wait and watch conservative grafting, and that is the answer.
One thing I wanted to add, the presenter mentioned that the left fifth digit is missing. Rather than that, it is better to say that it is disarticulated at the metacarpophalangeal joint or interphalangeal joint, or amputated at whatever proximal phalanx or distal phalanx.
Okay, sir.
Yeah, thank you, Dr. Jwana.
Please continue.
Thank you.
As the last thing, please remember, if this kind of a case, you will get maybe led on to operations for chronic lymphedema. You'll have to know what your Swiss roll operations and your other Stenson's operations and
Correct,
RD.
sir.
So that will most likely be your
Once
diagnosis.
there is wound is
Your
well
discussion
healed
on
or
that.
in LD, that's what probably will come into picture.
Thank you. Move on.
Right.
Next case, welcome
next
Dr.
case,
Simily. Simily, are you ready? Dr. Simily, yeah. Proceed with your presentation. You have 45 minutes. Please proceed, Doctor.
Yes. Good evening, everyone. Presenting a 67-year-old gentleman hailing from Krishnagiri, a manual laborer by occupation, presented to the OPD with the chief complaints of dilated veins over the left lower limb since 6 years and pain in the left leg since 1 year. History of presenting illness. Patient
Can I interrupt? Can we keep this as a short case instead of a long case?
Sir,
I think so, sir.
No, sir, the time is fixed for 45 minutes discussion, and PVD next case is also 45 minutes.
Yeah, more. Correct. So if it is presented as a short case, you have more time for discussion.
Correct, sir. Relevant things can be discussed.
Okay, yeah, positive things.
Sir, I think so. Let her finish the presentation completely and then we start the questions rather than interrupting her so that she can finish faster.
Yes,
Go to Simily.
Yes, sir. Please, doctor.
History of presenting illness. Patient was apparently well 6 years ago when he noticed dilated veins over the left lower limb, which was insidious in onset, progressive. Initially, it started over the inner aspect of the left lower leg and gradually progressed upwards till left mid-thigh. It was also associated with the swelling of the left lower limb, which was aggravated on prolonged standing towards the end of the day and relieved on lying down and with elevation of the limb. He also complained of pain over the left lower leg since 1 year. It was insidious in onset, dull aching type, more towards the end of the day, and aggravated on prolonged standing and walking and relieved on lying down. He also gave his complaints of discoloration of the skin around the left lower leg and ankle joint circumferentially and on the dorsum of the foot. And history of occasional itching also was present around the left ankle joint. Past history. There was no history of any pain or swelling in the calf region with fever or pain along the course of the veins. There was no history of prolonged immobilization or hospital admission. There were no history of trauma, no history of prior treatment for the similar complaints, and there were no non-medical comorbidities. Personal history, he consumes a mixed diet, with no history of alcohol consumption, smoking history, or any other substance abuse. Sleep and appetite were normal. Bladder and bowel habits were normal. Treatment history, there were no history of any surgeries for the similar complaints in the past. No family history.
Go to the examination.
On general physical examination, patient is conscious, oriented to time, place, and person. Is a moderately built and nourished with a BMI of 23.7 kg per meter square. Pulse rate was 78, which is regular in rhythm, adequate volume, normal in character, with respiratory rate of 16 cycles per minute. BP was 120/70 millimeters of mercury, measured in right arm in supine position. There were no pallor, icterus, cyanosis, koilonychia, or lymphadenopathy. Patient was examined with verbal consent with adequate exposure. Inspection was done in standing position of the bilateral lower limb. The right lower limb, the attitude was normal. Was present around the right ankle joint circumferentially. And the left lower limb, which attitude was normal, with the discoloration of skin present around the lower leg ankle joint circumferentially and on the dorsum of the foot. Dilated veins were present. Tortuous veins were seen in the medial aspect of the left leg, which was extending till the mid-thigh. And also eczema and pigmentation was present over the medial aspect of the left ankle joint. And there were no ulcerations or erythema or scars of healed ulcers were present, and there were no cough impulse was present at the saphenous opening. On palpation, the right lower leg was normal. On the left, there were no tenderness no local rise of temperature or pitting edema or cough impulse was present over the left leg. On the Trendelenburg test 1 and 2 were positive. Tourniquet test also were positive. Modified Perthes test was negative over the left leg, with the Fagan's test being positive, and Schwartz test was positive over the left leg. There were no bruit or bruit were heard on the dilated veins. The sensation were normal, and the peripheral pulses were bilaterally palpable. There were no inguinal lymphadenopathy or no restriction of the joint movements were present. Examination of the other system, cardiovascular system, S1, S2 heard, with the respiratory system, bilateral normal vesicular sounds were heard, and no focal or neurological deficits were present. Per abdomen is soft with no organomegaly or no palpable mass. Summarizing, 67-year-old gentleman, manual laborer by occupation, presented with complaints of dilated veins of lower limb along the inner aspect of the leg and thigh since 6 years, which became prominent on walking, standing, and reduced on lying down, and limb elevation, with complaints of dull aching pain on left lower limb towards the end of the day, which relieved after taking rest. It was also occasionally associated with itching around the ankle joint. With the local examination, there were varicosities present along the great saphenous vein over the left lower limb with hyperpigmentation. My clinical impression is chronic venous insufficiency of left lower limb, C4 AS, EP, AS, and PR.
Well presented.
Yeah, nice presentation. Now, just 2 questions from my side. Can you kindly tell me how you do your Trendelenburg test, please? How was these tests done? Because it's a very commonly asked question. Please describe how you did the test.
Sir, there are 2 parts in Trendelenburg test, 1 and 2. In both tests, we ask the patient to lie down in supine position, elevating the limbs. We milk the veins and empty it, and also we compress the saphenofemoral junction with the thumb.
Okay.
And we ask the patient to stand up, or even we can apply tourniquet also just below the saphenofemoral junction, just below that.
It's better to apply tourniquet, sister, because thumb and the junction, you may miss it. So it's better to use a tourniquet at the level of the junction. Yes.
And the patient is asked to stand up quickly. And if in the first one, if we are removing the tourniquet, and we will look for a filling of the veins from above downwards. And if there is filling, it indicates that there is a incompetent SFJ. And in the other one, in the second part, we are keeping the tourniquet applied over the same side and looking for the filling from below upwards.
Yeah.
Time duration. What is the time duration in number 2?
Around 1 minute, sir.
I think it's less than a minute.
Yeah, it's in less than a minute. Yes.
Yes.
It's a rather quick filling that can occur. Over a period of time, these veins will also fill up, but it is a quick or a rapid filling from below upwards. That indicates perforator incompetence. Yeah.
What tourniquet would you use if you're given a choice?
What tourniquet would you use?
We'll use the IV set lines of IV.
Okay.
Okay.
we were always using Foley's catheter, you know. IV line is good. IV catheter is also good. I mean, IV discarded IV line is also good.
Yeah, it's one of my uses of Foley's catheter. When I give it to the students, I ask them, what are the various non-drainage uses of a Foley's catheter? One of them is use of a catheter as a tourniquet. Yeah. Anyway,
Sister Simily?
Yes, sir.
Did you comment on short saphenous territory? No, you didn't. I think you should better to mention.
Very
Yes,
correct.
sir.
It should be mentioned. There are two systems in the leg, long and short. Whichever one you examine, the other one should be mentioned as being normal or not. Yes.
Okay, sir.
What are the clinical signs you elicited that say there is no DVT?
The clinical two tests are Mohs and Homan's test, which were negative, where the
Both are positive only in acute DVTs, no? For chronic
Yes, sir.
DVTs? How would you say the deep veins are patent? Clinically,
You mentioned the stitch in the tablet column, sister.
yes.
with the modified
Perthes,
Perthes
yes.
test.
Yes.
Exactly.
Yeah. Modified Perthes test is what is done. And how do you do that test?
How do you do it?
Sir, we will ask we'll ask the patient to stand up and apply tourniquet at the saphenofemoral junction, and we will ask the patient to walk fast, and if he is complaining of any severe pain at the calf muscle, it says that there is DVT.
You applied at the saphenofemoral junction?
Or where? Where is the correct place to apply?
Upper part of the thigh, sir.
Okay. Little part of the thigh. Okay.
So, what is this Schwartz test, sister? You are written positive.
Third test is we ask the patient to stand up, and we will mark we will ask the patient to stand, and we will look for the most dilated veins, and we will tap over that bulges, whatever we've seen. Then we'll feel the impulse at the SFJ.
SFJ. That so you said varicose veins are limited to lower third of the thigh. So I don't think you can do this test. That is one. What is this Bruy and dilated veins? Where do you get?
If you mentioned
Is it relevant?
tell us
But
where
all
you get it.
where can you get it?
Yeah. Which conditions where veins are seen and you get a bruema?
AV malformation.
Yeah. Yes, it is in the AV malformation, hyperdynamic circulation. Yeah.
In fact, when you mentioned that, I thought you would also mention limb length discrepancy. When you mention Bruy, look for limb length discrepancy.
Correct. Yes.
Both should come together, sister.
Okay, sir.
Okay, how do you go about, sister?
What would you do for this gentleman? Laborer, poor chap.
Last but one slide, what is output? Just show me.
Sir,
the C4ASE, we just put, what is this? I'm not understanding. C4ASEPASPR.
Sir, it is divided into clinically and ecological.
CEP class.
Yeah, with each one described. Yes. Go ahead. You're correct.
Clinical, etiological, and anatomical and pathological, pathophysiological diagnosis, sir. Clinically, it is 4A, which means that pigmentation or eczema is present clinically on examination, and S is
E is etiology. Primary or secondary?
Somebody, so please mute yourselves. There's an overlap of conversation. Is there any other classification other than the CEAP, sister? CEAP is clinical, etiological, anatomic, and pathological, pathophysiological. And each one has got various grades and numbers so that you get different connotation, which gives you the correct anatomical diagnosis of what, or correct diagnosis of the degree of varicosity is present in that patient. What is the VCSS, ma? You've heard of the VCSS? It's a Venous Clinical Severity Score, which has about 10 parameters and you score them. That also is now being asked for. So you can just keep a note and see what that is also. Right, what do you do for this patient?
What is the vein of Giacomin? Are you aware of vein of Giacomin? It can alter all your findings.
Yeah, just Dr. Tell them, please.
It is a communication between the short saphenous vein and the long saphenous vein. The vein runs from the end, almost the terminal end of the short saphenous vein, and goes up and communicates with the long saphenous vein. So all these clinical signs will be missed. I mean, will be assessed improperly. It's quite a common occurrence, anatomical abnormality.
What is the percentage of vein of Giacomin?
Maybe around 30%.
You should keep in mind, sir. Yes, as you said.
How do you manage?
How do you go about?
What will you do for this chapter?
What next?
After the thorough examination, history and examination, we'll go with the investigations. Initially, I'll go about with the routine blood investigation. Following which, I'll go for radiological imaging, especially when planned for any surgical management. Here, I'll go about with the duplex scan.
The only thing that you didn't mention in clinical examination are where are the perforators?
Below knee, sir. Below knee perforators.
No, how many? One perforator.
How many marked for perforators?
3, sir.
Could you mark them?
3, sir.
3 where? 3 where? Ankle, below knee,
and above knee, sir.
Above knee.
Yes, sir.
All 3.
What are the named perforators? Can you name them?
Sir, at the angle May and Custer perforators, and below knee there are Boyd's perforators. Cocket perforators, and below knee it is Boyd's perforators, and below thigh it is Dodd's perforators, and the proximal part of the thigh is Hunter's perforators.
Simple. CBD from below upwards.
I just typing that out now. But
high perforator is, a 4th perforator. The clock is 3 or more.
Yeah. Okay. Good. Now, what did you do? You're evaluating. You said Doppler, duplex. What do you mean by duplex, please?
It is B mode ultrasound with Doppler, sir.
So, what does it tell you?
What is B mode? What is Doppler?
Sir, B mode ultrasound is the normal ultrasound what we do, which is where we use the probe of 7 to 15 megahertz.
Mode. B is brightness mode.
Okay,
and
sir.
B gives you the anatomical structuring, okay, the size of the vein and the length of the vein and all that. The Doppler, the effect gives you the velocity and direction of the flow of blood, okay. So
Yes,
that
sir.
is why these two are combined and gives what is called the duplex ultrasound, or that is what is used to assess vascular structures.
Yes, sir.
All right.
Yes, sir.
Okay. So what is the
Scan report?
What is scan report, please? What did the radiologist tell us?
So here patient was did not come back to the exam.
Or what you want to know from radiologist, sister? What are the things you would like to know from radiologist?
Presence of presence of reflux in the deep veins or in the superficial venous system, and also the extent and the duration of the reflux, and also any deep vein thrombosis present or not.
Okay.
And in presence of any obstructions and the perforators, and to know the competency of the perforators.
Okay, then incompetence or competence? You
Sorry,
which is
incompetence.
Incompetent perforators. And more important than that, from the surgical point of view,
the diameter of the
diameter.
Surgical point of view.
Surgical, see, all your thoughts should be on surgical view, isn't it? What you want to operate, how you want to operate.
Junction, sister.
Yes,
SF
sir,
junction
yes,
and
sir.
SP junction
Yes.
are important, no?
Yes, sir.
First, you should mention that, then everything else.
Okay, sir.
Okay. So why do you want to treat this guy? I mean, what's your indication for surgery? The legs look fairly all right. He's not showing his legs everywhere. His veins can be under his clothes. Why do you want to offer surgery to this man, or a treatment to this man? And in treatment, what is conservative? What is operative?
Based on the CSEP classification, it is more than grade 2. Usually we'll go for a conservative or as well as surgical management.
You decide, sister, which one you want. What are you going to advise this laborer chap?
Why is the surgery required? Sir is asking.
Why is surgery required? That's what I'm asking.
Because of the associated complications.
Like
venous ulcer formation.
No, tell us something which patient. Tell us something which patient already has due to varicose veins.
Patient has got eczema, and also pigmentation is present. Also, he has got occasional itching over the
So
left
early
ankle
signs of
joint.
chronic venous stasis has started occurring. So that is one indication. What is something that can be life-threatening for this fellow?
Bleeding, sir.
Correct.
These veins can bleed on trivial trauma. They are laborers, they hurt themselves, they can have trauma. What would you do if you see somebody with varicose veins who's bleeding badly on the roadside?
Compression.
No,
elevation.
Elevation. Elevation you tell.
Yes, elevation. Please remember, all forms of compression in the erect positions will increase the flow and bleed. You just have to make the patient lie down and elevate the leg, and like magic, it stops. This just stops immediately. Even in OTs, you've seen when we do the stripping and then we lift the leg for some time, all the bleeding stops. So it is a important thing to remember that the bleeding is always gravity related, and once the forces of gravity can act on it, it can cause a lot of bleeding. Yeah.
Has this patient got symptoms or no symptoms?
He has got the symptoms of dull aching pain is there, sir, since 1 week.
So all symptomatic varicose veins need treatment.
Need to be treated.
Okay.
Yeah.
That's point number 1.
Yes.
And looking at the grade that you mentioned, he needs surgery.
Yes, sir.
What surgery you want to do, ma? What surgery you want to do?
Sir, the gold standard is ligation, flush ligation and stripping.
Flush ligation of what and stripping of what, ma?
Flush ligation of the saphenofemoral junction and
junction or of the vein at the junction.
Of the veins at the junction.
Yes.
And stripping of the GSP, sir.
Right.
Till where, sister, and why?
It's only below. It's above knee, sir, because below knee.
Above knee or below knee?
Stripping is done above knee or below knee?
Below knee.
Aye.
No,
Up
sister.
to just,
No, you
up
told
to just below knee. Up to just below knee.
Yeah. Please remember, the
Right.
old adage in treatment was to strip the whole length of the vein, but certain number of patients came back with the neurological effects of being saphenous nerve being taken off also, and that caused some symptoms in the foot. So they say you don't strip the vein below the knee. So you strip only up to
Just
and
up.
just below the knee. Beyond
Just-
that, you don't do any more
Yeah.
stripping.
Can I add a second reason also? That
Yes.
you need the vein of the leg for CABG.
No more use, sir. No more use.
Unless it is
What is this,
varicose, you don't use it.
The varicose veins cannot be used at all, no, sir.
Yeah. You have a posterior arch vein which can be used. Okay.
Okay, Sister
What is
Simily.
Gator's area, sister? What is
Yes, sir.
Gator's area?
Gator area.
Gator's area is the medial aspect of the ankle joint, sir.
Please
Why
think
it is
again.
called Gator's area?
No, only medial aspect.
What is the meaning of Gator?
Why it is called Gator's area?
Because the maximum number of perforators are present at this area, and also the subcutaneous tissue is less, and the
No. What is Gator? I think Rajan would be able to tell us what exactly is Gator.
Rajan sir will describe everything about Gator.
Sister, what is the surgery you described?
Yeah. Sir,
Flush ligation?
I'll call you back.
Sister
Yeah.
Simily,
What is the name,
Sir?
sister?
Trendelenburg
what is the name
procedure.
of the huh?
Trendelenburg procedure.
Trendelenburg? What are the components of Trendelenburg surgery?
Flush ligation
Hmm.
and stripping.
Stripping is not component of Trendelenburg
No.
surgery.
You need to ligate something, no, before Trendelenburg. What is that?
I think she said flush ligation.
No.
What are the name tributaries you want to ligate? Simile?
Tributaries. You need to clear them, no, before. What are the
Yes.
tributaries?
3 tributaries, sister. Named 3 tributaries, and you have to ligate unnamed things also.
Yeah.
Tributaries also.
Me,
And one more thing you should remember is that stripping is not a component of Trendelenburg surgery. You are going to take out only proximal 10 centimeter, 8 to 10 centimeter. Stripping
Yes,
is an additional procedure.
yes,
That is not a part of Trendelenburg's.
And you forgot perforator ligation also, right?
Yes.
Subfacial
Yes.
ligation, perforators.
How would you deal with those perforators at the below the leg, ankle, below the knee that you have elicited in your history, sister? Your say T2 is positive. How will your Trendelenburg operation help with that?
inject form sclerotherapy can be used.
No. You're doing
You can't
surgical
use them for
intervention.
perforator.
What will you complete your surgery? What will you do? Dr. Srivatsa just mentioned it.
In fact, the day before
Perforator
surgery,
ligation.
in fact, the day before surgery, you'll do an ultrasound, isn't it? Doppler to mark what?
Yes. Perforators to mark the perforators.
So you can do stab avulsion of perforator from single incision. You can do seps and that is cut all the perforators. There are many methods of dealing with these, or single incisions and ligation of perforators. So there are various things that you have to do to deal with the incompetent perforators, so that the nutrition of the circulation in the area is kind of restored. If you don't deal with perforators and you have an ulcer, the ulcer never heals. The perforators need to be tackled. Yeah.
If suppose this patient doesn't want surgery, sister, what options will you offer?
We'll offer compression dressing along with the limb elevation, and also venoactive drugs can be.
No, what I'm trying to ask you, sister, is
Yes.
apart from
Yes, sir.
surgery,
Yes,
is
to
there
earn
any other
livelihood.
ways to deal with the long surface system or the short surface system? which we do.
In other words, is there any minimally invasive technique?
Yes, sir. The
Name them, sister.
endovenous procedures like endovenous laser and endovenous radiofrequency ablation.
Please remember today, less and less surgery is being done for varicose veins, and more minimally invasive surgeries are done so that the result is as good and the recovery is much faster. All right.
Apart from radiofrequency, anything else you have, sister?
Endovenous glue can be used.
How do you classify varicose veins?
Telangiectasia less than 1 mm and
reticular veins
1 to 2.9 mm. Varicose veins more than 3 mm.
Truncal varicose.
Truncal varicose veins more than 3 mm.
What is Klippel-Trenaunay syndrome?
It's a congenital syndrome where skin, bone, and varicose congenital malformation, AV malformations are present. Bone hypertrophy, nevus.
Hypertrophy of soft tissue and mesodermal structures, cutaneous nevus, and vestigial veins showing varicose.
Varicose.
Okay, good. Good.
Can you tell me another operation with the eponym of Trendelenburg, sister? He does another vascular operation. In former days, they used to do open pulmonary embolectomy. He is one of the chaps who tried to do it to treat acute pulmonary embolism, and that operation is credited to him as Trendelenburg operation. Any other Trendelenburgs you know of? Have you heard of other Trendelenburgs? Yes?
Trendelenburg position is.
Position, very good one. Because you're doing vascular work also, you need Trendelenburg position. What is the normal Trendelenburg? What is Trendelenburg position?
The lower limb is and the
reverse Trendelenburg system. Normal Trendelenburg is head end elevation. Okay, that is the position. I don't know why, but what we all lower elevation is called reverse Trendelenburg.
Reverse Trendelenburg.
Yeah. What is the Trendelenburg gait? You've heard of Trendelenburg gait? In congenital dislocation of the hip, you find that there's a dropping of the gluteal or buttock fold on the side of where the dislocation is there when the child is made to walk. That's called the Trendelenburg gait.
Okay, sir.
Yeah. Okay, this person, since we have, do we have any more time or should we stop?
Yes, sir, we have time, sir. Please discuss it.
What's the last case?
PVD, sir.
PVD.
I think we'll, sir,
okay, we'll stop this. I think we have to, PVD has got much more discussion in it and more relevant. Sister, you've done a good job. If you come to me as a student, I would be passing you quite well on your performance. Please remember, you don't have slides in the exam. You'll have to present from your mind and memory and be a little more fluent, be bold, be confident in your approach. Well done. Thank you.
Okay, sir.
Well done, well done.
Well done.
We'll call upon Dr. Alfin.
Yes, sir.
Alfin.
Good evening, sir.
Yeah.
Presenting a case of peripheral vascular disease.
There is an echo from your system.
If there is any other system, please tell them to mute.
Patient was a 45-year-old gentleman, sir, who presented with these complaints. He presented with complaints of left calf and foot pain for 3 months, which had aggravated for the past 2 weeks, and a non-healing wound over the left foot for the last 1 month, sir. History of presenting illness: patient was last normal approximately 3 months ago, when he developed claudication pain of the left calf and foot. Pain was aggravated by walking. Initially, patient was able to walk 200 meters distance, after which he developed claudication pain, initially relieved by rest. Currently, patient has rest pains for the last 2 weeks. Pain is of continuous burning type involving the left leg and foot. There is no history of numbness or reduced sensation over the foot, sir. No history of diurnal or postural variation in pain. No history of trauma to the limbs. Further, patient also complains of a wound over the left foot. Approximately 1 month ago, he developed blackening and pains involving the left, third, fourth, and fifth toes. So patient was evaluated and he underwent stenting, he underwent stenting by interventional radiology. Afterward, he also underwent disarticulation of the left, third, fourth, and fifth toes. The resulting wound failed to heal and progressively increased in size. Patient gives history of foul-smelling pus discharge from the ulcer. No history of fever or trauma to the foot is noted. Patient is also a known case of ischemic heart disease. He has history of myocardial infarction 2 years ago, which was managed conservatively. There is no history of suggestive of transient ischemic attack or stroke in the past. No history of postprandial abdominal pain, or no history of erectile dysfunction, sir. Medication history: patient has been on dual antiplatelet agents post myocardial infarction, which he is compliant with. Patient is a known case of type 2 diabetes and hypertension. He is under treatment with injectable insulin and angiotensin converting enzymes respectively for the same. Personal history: patient is a smoker. He has 20 back years spent smoking BDs, and history of chronic alcohol intake is also noted, 4.05 units a day for the last 30 years. Patient gives history of sleep that is disturbed by pain. He consumes a mixed diet and bowel and bladder habits are normal. Patient is a farmer by occupation. He hails from Anandapur district of Andhra Pradesh, and he has been unable to work since the onset of pain. So history summary: patient is a 45-year-old male, known smoker with ischemic heart disease, type 2 diabetes, and hypertension, with complaints of left lower limb claudication pain, which has progressed from Boyd grade 2 to grade 4 over 3 months, and also complains of a non-healing ulcer over the left foot for the last 1 month. On examination, there was no pallor.
Dr. Alfin.
Yes, sir.
Let him finish his examination and we'll come to him. Counselor, please.
This history level itself.
Okay, you stopped at history then.
Are you able to come to some sort of conclusion break with the problem?
Based on the history, what is your thoughts, impression?
Because with respect to peripheral disease, you can get a lot of information and you can almost point problems with respect to the vessel which is involved. So what are your thoughts?
First, with regard to the patient's, yes, with regard to the patient's presenting complaints, sir, my primary thought would be claudication pain secondary to vascular arterial pathologies. Secondly, with regard to etiology of the vascular pathology, I would like to think of atherosclerosis at this stage. The second differential diagnosis.
Joe, first, whatever you're talking, you're mentioning arterial disease. Please mention why you're thinking it is arterial disease based on the history.
So there are hard points and soft points pointing towards the same. Hard points: patient gives history of pain that occurs, pain involving the leg that occurs on exertion, reproducible pain that was initially relieved at rest by rest.
So basically, a patient has claudication pain.
Claudication pain, yes, sir.
Yeah, use the right terms.
Yes, sir. So which progressively worsen, which progressively worsen to rest pains. So secondary factors: patient is a known diabetic, hypertensive. He already has history of a previous thrombotic event. He's also a known smoker. All these are soft points that would lead me to think of the diagnosis.
What is the meaning of thrombotic episode?
So he has already had he's having history of myocardial infarctions.
Say that. He says coronary
insufficiency.
Yeah.
Coronary.
Now, can you tell me what is the grade for? I thought claudication is grade 1, 2,
1, 2, and 3. Yeah.
We are confused with rest pain.
Yeah, rest pain is different.
Different, yeah.
Now, explain what is claudication pain. Can you tell us what is claudication pain characteristic and differentiate it from neuro claudication?
Yes, sir.
Venous claudication.
The claudication pain is defined as reproducible muscle discomfort that is induced by exercise and is relieved by taking rest for less than 10 minutes.
Less than 5 minutes. Not present with the first step. Not present with the first step. Relieved within 5 minutes of taking rest, either in the standing or sitting position, and is a vise-like grip or a crampy pain in the muscle involved. What is neuroclaudication?
Please note every word of Dr. Srivatsa is very important. The figures that he has given of 5 minutes and other things give you the difference between the different types of claudication. So that is why it's important to note that. Yes, venous claudication.
The pain reduces completely within 5 minutes. The pain, there's no residual pain after the 5 minutes.
In claudication, correct?
Yes, sir.
Yes,
yeah,
sir.
okay.
So what is
neuroclaudication? Can you tell us what is neuroclaudication? It's exactly opposite. You should be able to tell us.
The neuroclaudication is characterized by severe shooting type pain that often radiates downward from the back towards the affected lower limbs. Pain is often, neuroclaudication pain is experienced from the first step that the patient takes.
Correct.
And it may take longer than 5 minutes to resolve if the patient does take rest.
In the sitting position.
Posture.
And it may also be associated with motor and or sensory deficits.
Abnormal postures aggravate the pain. Venous claudication.
Venous claudication is described as a bursting type of pain, sir, typically involving the thigh.
Not a bursting pain. Can you just say, rephrase it? Bursting is DVT.
DVT only is bursting. What is the other type of pain in venous claudication?
Dull aching pains of chronic venous infection.
Heaviness
or dragging pain.
Yes. And when is it severe?
Severe when the patient is standing, sir, or may be resolved by elevating the limbs.
At the end of the day. It reaches the peak at the end of the day. When he's working at the end of the day, when he goes home, he has the pain. And then he has to raise his limb to get relief. Okay.
So in this patient with the history, what you have, Alfin, with the disease, with the symptomatology, where do you think could be the cause for the problem? One, yes, you said it's a arterial problem.
Yes, sir.
Okay. Anatomically, can you locate which vessels could be involved?
Yes, a patient is very particular that pain is involving the leg and the leg and the foot. So I would like to think of either distal femoral or popliteal disease. I would like to think of.
Okay.
You please classify it as the muscles of the leg. So it is involving the calf muscles and the dorsum of the foot. These are the ones that give you the pain in claudication. So that will give us, if you just say leg and foot, we don't know what exactly where it is. Okay, so localize it.
Can you tell the anatomy of the vessel?
The anatomy of the vessel,
from the femoral artery.
From the abdominal aorta on one side.
So the abdominal aorta splits at the umbilicus level, sir, to give off the common iliac artery. The common iliac artery in turn splits off to give the internal and the external iliac arteries. The external iliac artery continues as the femoral artery below the level of the inguinal ligament. It continues as the common femoral arteries approximately. Below the level of the profunda femoris artery takeoff, it is referred to as the superficial femoral artery. It becomes the popliteal artery when it leaves the adductor hiatus. When it leaves the adductor magnus, it begins, the popliteal artery begins. following which there is a bifurcation, sir. It travels posterior to the knee joint, and there is a bifurcation following which the posterior tibial artery runs in the posterior compartment. The anterior tibial artery pierces the interosseous ligament superiorly and runs downwards. The anterior tibial artery becomes a dorsalis pedis when it gets down in the first intermetatarsal space and splits into the medial and lateral plantar arteries on the sole.
There's a small correction. It's after the popliteal breaks into a trifurcation. There are three tributaries that three branches that come off there. One is the peroneal. What you missed is a peroneal artery, which can become important if the other two are blocked. Okay.
Yes,
so just remember, it's a trifurcation. The rest of your analysis is correct.
Yeah. So it's an
Alfin, the umbilicus is not a constant anatomical point. You said that aorta divides at the level of the umbilicus.
Level, please.
Umbilicus is not a constant point. What level? Which vertebral level?
The level of the disc between L1 and L2.
No. It's too high. It's too high.
No.
L1, L2 is too high. It's around
You
L4.
take off the renals then, man.
It's around L4. L4 by
L4 actually.
L4.
Yeah. L4.
Okay, so what I'm trying to illustrate, Alfin, knowing this anatomy and the symptomatology, you can sort of say where the problem is. Okay, so that is why you have to spend time on the history taking of your symptomatology.
Just two anatomical questions. What are the branches of external iliac artery?
Gives off the inferior epigastric arteries.
Good. Yes. And
the circumflex iliac arteries.
No. Circumflex iliac come off the femoral. Where is the, what is that? Is there any other branch?
Yeah, I think it's deep circumflex. Deep
circumflex, yes. It is circumflex. Superficial circumflex is from femoral. Deep circumflex is from external iliac.
Second question is, what are the anastomotic, the branches between the iliac artery and the femoral artery or the popliteal artery? What do you get and what do you call them? These are important for collaterals to develop.
You gave the word, man.
First is the profunda femoris artery is one branch.
Cruciate
arteries around the knee joints.
Yeah, correct. And above femoral to iliac. Sciatic. You get the arteries coming out the sciatic foramen, supplying the gluteus, and you have branches at the top end of the profunda. Okay, go on.
Okay.
Before going to examination, no, wait.
Sorry.
So you didn't mention one point. After stenting, were the symptoms relieved?
So initially there was
endovascular procedure.
So there was relief of symptoms for a few days, approximately a week, as per the patient's report for post-stenting, following which again the previous symptoms records, chest pain.
What do you think has happened?
So there is a possibility that the stent has thrombosed, or there is a possibility that a new thrombus has formed at a different location.
Mostly stent thrombosis. New patient, if patient is compliant, no, mostly it's even if patient is compliant, stent thrombosis is most common. Then new thrombus elsewhere. Okay, and the rest pain you mentioned, there is no postural variation. Usually there is a postural variation, right?
So yes, history patients with rest pain usually say that there may be a decrease. I had asked if there was decrease in pain when he let the leg hang off the bed. As per the patient, there was no difference in pain, according to the patient.
Okay.
How do you? Yeah, go on.
So on examination, there was no pallor, buttress, cyanosis, clubbing, lymphadenopathy, or pedal edema. Vitals, patient's heart rate was 89 beats per minute. It was normal in rate, rhythm, character, and volume. The vessel wall, condition of the vessel wall was known to be thickened. BP was 140 or 80 millimeters of mercury in the left upper limb with the patient supine. Saturation was 99% on Romac. Temperature was afebrile, and BMI was 22.8 kg per meter square. This is an image of the patient's legs. On local examination, patient's attitude, patient was seated with the foot on the bed, and he was holding it in both hands. On inspection, there was wasting of the left side calf muscles noted compared to the opposite side. There was loss of hair and subcutaneous tissue over the left leg and foot compared to the opposite side. Bluish black discoloration of the left second toe was present. There was no intermetatarsal hollowing. Guttering of veins was present. There were no brittle nails. And there was a presence of an ulcer over the site of the former third, fourth, and fifth toes, a post-disarticulation ulcer. So the ulcer was approximately 6 into 3 centimeters, noted over the lateral part of the dorsum of the left foot. The margins were necrotic and edematous. The edges were sloping in parts. The floor of the ulcer was seen to contain slough with pus discharge noted within. On palpation, the margins of the ulcer were tender and edematous. The floor was again containing slough. Base of the ulcer was made up of bone, and inguinal lymph nodes were enlarged 2 into 2 centimeters. They were non-tender and mobile. On palpation of peripheral pulses, the radial and ulnar arteries were palpable bilaterally. On palpation of the peripheral pulses of the left lower limb, the femoral artery was palpable. The popliteal artery was feeble. And the distal arteries, the anterior tibial, posterior tibial, and the dorsalis pedis were not palpable on the left. On the right side, radial, femoral, and popliteal arteries were palpable. The anterior and posterior tibial were feeble, and the dorsalis pedis was not palpable. On local examination of the left lower limb, the left foot and ankle were cold. Left distal part of the foot and the ankle were cold compared to the opposite side. Capillary filling time over the left foot was more than 3 seconds. A Berger's angle of the leg could not be elicited due to dark complexion. Patient's ankle brachial pressure index over the right lower limb was 0.6 and over the left lower limb was 0.3. On sensory examination, the sensations of fine touch, coarse touch, and temperature were reduced over the sole and dorsum of the left foot. On motor examination of the bilateral lower limbs, on examination of the left leg, both hip and knee flexors and extensors had 5/5 power. Ankle flexors and extensors had 3/5 power. And great toe flexors and extensors were 0/5. On examination of the other systems, cardiovascular system, SO and S2 were heard with no murmurs or gallop to them. Respiratory system, bilateral normal vascular breath sounds were heard with occasional crepitations. And there was no focal neurological deficit noted. For this patient, I would like to give a diagnosis of peripheral vascular disease.
Hold on. I think we must ask the experts whether they're happy with your examination stepwise. Sir, Epsur, Sridhar, are you happy with what he has said on examination?
I think so. You should more better and elaborate, I feel. What can you do?
He came out with the pulses first, right?
Yeah.
Examination of the peripheral pulses first. And then I don't know whether he spoke about the superficial signs of ischemia.
He has not mentioned about it.
Inspections, no superficial signs of ischemia, no guttering of veins, whether veins are full or guttered.
I had mentioned.
Yeah, he had mentioned. He's mentioned, yeah.
But he was not emphasizing it. Can you go a slide? He did mention.
Yeah. Okay. It's there, right? Good.
It's attitude and all that he mentioned. Yes.
Okay. Fine.
Tell me how you palpated for the popliteal artery, please. How do you normally palpate popliteal?
The popliteal artery, the patient is made to lie supine. The knee is flexed and the popliteal artery is felt against the superior part of the tibias.
What aspect of the tibia?
The posterior aspect of the tibia.
I know posterior, man. What aspect of the tibia? Against the condyles of the tibia. Okay, right. Any other method?
Which position?
He mentioned supine, yeah.
Supine.
Supine with knee, yeah. Any other method of feeling the popliteal? Sometimes this you cannot feel.
Patient can also be made to lie prone.
Yes.
Can be palpated against the femoral condyles.
What's the position of the knee?
He has to be flexed.
Why? That the tenseness of the popliteal fascia is reduced, and your allows you fingers to dip into the popliteal fossa and feel the artery properly. I personally feel this is a better way to palpate the popliteal artery in the prone position with the knee flexed, and then you feel against the condyles of the femur. Right.
Alfin,
if
yes.
you're able to feel the popliteal artery prominently, Alfin, the first, are you happy about it, or would you like to suspect something? A very prominent pulsating popliteal artery.
In that case, we have to consider the presence of a popliteal artery aneurysm. Possibly.
Yeah.
So an easily palpable popliteal artery is not necessarily a good sign.
Yeah. And remember, popliteal artery is the most common of the peripheral arterial aneurysms that can occur. So that's why, which is an important thing to look for. Yeah. And then,
Alfin,
yes.
Infrapopliteal, you are not able to feel any of the pulses, no? So how did you get ABI?
The ABI, I used a Doppler probe to assess the signal.
Please mention that, okay? Yeah. Lastly, how do you palpate the femoral artery? What's the attitude of the limb when you palpate the the femoral artery?
So the hip joint has to be externally rotated. So
yes.
Bring the head of the femur out, and the femoral artery can be palpated.
With mild flexion also. Mild flexion at the hip in external rotation, so as to make the head prominent, and you feel it against the head of the femur. At what anatomical point?
Abduction also.
Yes.
And abduction also, yes.
At the midinguinal point.
Yeah, which is?
So half the distance between the anterior superior iliac spine to the pubic symphysis.
Yeah, there's some people used to split hairs about it. I'm just saying it. It is controversial that they made a midpoint of inguinal ligament between anterior superior spine and pubic tubercle as being the thing that is no longer accepted. It is mid-inguinal point, and it is, as you rightly said, pubic symphysis and anterior superior spine. But unlike the deep inguinal ring, where you're 1.5 centimeters above the mid-inguinal point, here you're at the mid-inguinal point. Okay, that's the difference. Yes. And
yeah, how would
the
you
artery that is
grade?
palpated, please know
How would you grade the ischemia?
How do you grade ischemia? Yes.
So we can grade it clinically on the basis of the Rutherford classification, sir. So in the Rutherford classification, grade 0 is an asymptomatic patient. So grade 1 is the presence of mild claudication pain. Grade 2 is moderate claudication pain. Grade 3 is severe claudication pain. Grade 4 is the presence of rest pain. Grade 5 is the presence of minor tissue loss, and grade 6 is the presence of major tissue loss.
So this one is which grade?
So this patient will be Rutherford grade 6.
Okay, fine. What is the other type of grading?
Other grading is the Fontaine classification.
Fontaine, okay. There is no 0 in Fontaine. All right?
Yeah.
So what's your diagnosis? I mean, we were at the diagnosis when we interrupted.
So diagnosis, left side chronic limb-threatening ischemia, possibly secondary to atherosclerotic disease involving the femoropopliteal segments, with the presence of tissue loss.
Use the word limb-threatening ischemia. Kindly use critical limb ischemia. Yeah? That is understood that it is going to be impending tissue loss. So you use the word critical ischemia.
Critical limb. Say gangrene. Gangrene due to. Gangrene of which portion? And then due to obstruction at what level? And then the cause of obstruction.
Correct. Yes.
Yes.
Sir, now that critical limb ischemia was used before, now it's changed to chronic limb threatening ischemia. The nomenclature has changed recently.
Okay, I beg your pardon. I have not known
No, sir.
that. If
No,
that
sir.
is so, then you please use it that way. Okay.
I think the diagnosis should be what is apparent to you. There is gangrene.
Yes.
Is it dry gangrene, wet gangrene? So first thing is it a dry gangrene, wet gangrene? And what is the cause of gangrene? And what is the pathology of the cause?
In this patient, there appears to be wet on dry gangrene, because the patient has already given history of blackening of the venous. And now there is pus discharge that is visible.
So you have to mention that, isn't it? Instead of saying critical limb ischemia, which we know is gangrene, is it dry and wet superadded and dry gangrene due to infrapopliteal obstruction due to atherosclerosis or diabetes? Hello?
Yes,
Yeah.
sir. Yes, sir.
Yeah.
Sir, due to atherosclerosis in the case of this patient.
Yes. Yeah, go on. What would you like to do?
Why it's not Burgess disease?
So this patient does not fulfill two of Jwana's criteria, sir. Patient is 45 years old, and he does have history of smoking. However, he has history of diabetes mellitus. That is one factor against. He has history of previous thrombosis. He has history of previous myocardial infarction. And also there was no superficial phlebitis that was apparent in this patient. So 3 out of 5 Jwana's criteria are not satisfied. So patient is unlikely to have Burgess disease.
So your diagnosis should include diabetes also, isn't it? Atherosclerosis due to diabetes. Because diabetic atherosclerotic disease distribution is different from classical senile atherosclerosis. So you have to add diabetes mellitus. What is the peculiarity of involvement of vessels in diabetes?
So it is a thrombotic microangiopathy. It involves
which vessels and what is the distribution?
Capillaries are involved, sir, in diabetes.
We're looking at macro. Bigger vessels, not the microangiopathy. We are looking at involvement of bigger vessels. So what is the distribution of involvement?
Distribution is primarily the large caliber vessels that are occluded, sir.
Large caliber would be what? I mean, how do you classify the caliber according to the caliber?
So large, medium, and small vessels, sir. Small and medium are in.
Large, medium, and small. Which is large, which is medium, which is small? You only opened it. Now you have to answer it. All direct branches of the aorta. All direct branches of the aorta are large. Okay?
Yes.
Medium are those which are coming from these direct branches. And the small ones, I think the caliber. I mean, I don't remember what is the caliber, but the pedal vessels are the small ones. So you get involvement of femoral artery and progresses distally, or popliteal artery and progresses distally, diffuse involvement. Okay. So what do you want to do?
In the case of this patient, specific and non-specific tests, specific investigations, biochemical, I would like to get a CBC, complete blood count first. First, I would like to look at hemoglobin, because the patient is a smoker, probably having polycythemia, so which itself may contribute to a prothrombotic state in him. I'd like to get that corrected, sir. And also, patient has an infected ulcer, so I would like to look at his total count as well, to see if there's any active infection with him.
You expect it, isn't it? You expect infection.
To see, yes, sir.
Yeah. Okay.
Further, I would also like to get an RFT done, sir, for the patient, because he will almost certainly require radiological investigations. He will require an angiogram. So to rule out possibility of contrast nephropathy, I would like to get an RFT done as well, sir. And also PTI and coagulation parameters I would like to see, sir, because if we're planning on starting anticoagulation at a later stage, I would like to get a baseline PT-INR and APTT. And specific radiological tests, I would like to begin by getting a Doppler. Doppler to rule out the level of obstruction.
Yeah,
Patient has been stented.
Yeah, tell me Doppler. Okay.
So Doppler, I would like to pick up the presence of the level of the occlusion, sir, if possible. And patient has been stented before, sir. Presence of stent thrombosis, I would like to assess. And following that, I would also like to get CT angiograms.
Okay, what is Doppler? Arterial Doppler. Can you describe the meaning of arterial Doppler?
The arterial Doppler describes both the auditory and the color uptake signals. We're looking for both. We're looking for a triphasic auditory signal and the presence of color uptake in the affected vessels.
It is the real-time imaging. Real-time imaging of the artery and waveform representation of the blood flow in the vessel. Waveform representation of the pressure and the flow in the vessel. That is two combinations. So, you know, the waveform distribution, what is it called? How do you classify the waves?
It's called triphasic, biphasic, and monophasic.
Correct. Correct.
Yeah.
Correct.
What do you mean if it's
real-time
biphasic?
imaging tells you where is the block, how far is the block, what is the segment of block, the length of the block, how multiple segments, single segment. Okay, go on.
Yes, sir. So following that, for definitive thing, I would like to also get a CT angiogram. On the CT angiogram, I would like to look at the level of disease. I would like to look at the number of
why are you
degree of
mentioning CT? Why not MRI? MR angio?
He's a diabetic. His kidney function may not be good.
Maybe on a cost basis. A patient is a poor farmer from Andhra Pradesh. Maybe
No, we are not
MR
looking at
angiogram.
cost when treating patients. You are not taking that into consideration when you're discussing a case. CT has got a dye, isn't it? You have to inject a dye.
Yes, sir. Yes.
So diabetic, nephropathy.
Yes, sir.
Oh, so you have to make sure creatinine is normal, right?
Normal. Yes, sir.
Okay.
Right.
Radiation exposure. Fine. Go on.
So CT angiogram, I would like to look at, or MR angiogram, I would like to look at the level of occlusion, sir, the degree of occlusion, whether it's complete or partial stenosis, the length of the occluded segment, sir. And I would also like to look at the state of distal runoffs versus the state of the collaterals.
Which is the most important thing? Which is the most important thing? The distal runoff.
The distal runoffs.
Why not a direct angiogram on the leg, man? Opposite side femoral, direct angio. You are right what you said. I just want to know why you are not thinking of an angiogram.
And in the same way, what is DSA?
So digital subtraction angiography.
Yeah, tell us why not. That's a gold standard, right? Digital subtraction and direct angio.
Any reason why you do not want to do it? It is an invasive procedure, and only if you are having to do an intervention as a result of your non-invasive imaging, then you do the angiograms. Because interfering with these disease vessels and then not ending up doing anything at all has more risk than benefit. And so the risk benefit is with non-invasive measures like either the CT angio or the MR angio. And the difference between the two is detected entirely on the renal function status of the patient. Right. Do you have any news on what any of these investigations done? Did you have an ultrasound done, a Doppler done, or have you got any angiograms done?
Yes, sir. We had got an angiogram done that was showing a stent in the popliteal arteries
Okay.
that had been occluded.
Okay, it shows it's occluded.
Yes, sir. So patient was subsequently planned for femorotibial bypass.
No. You're not given us the findings at distal runoff.
Yeah, how do you do the surgery without knowing, man? We should know what's the tree root appearance.
So distal runoff was present.
Hmm.
Distal runoff was present on the CT angiogram.
Which vessel? Which vessel?
Sir, anastomosis was from the femoroposterior tibial. Anastomosis was done, sir.
The posterior tibial is very important, right?
Yes, sir.
So when will you do the stenting was done? What is the indication for stenting? In the sense, when do you do angioplasty and stenting?
So when it is a short segment thrombus, or less than 5 centimeters, and if it is a distally located thrombus that is not amenable for bypassing, sir, by using a venous graft.
I think your 5 centimeter should be extended to 7 centimeters. Previously 10, now it is 7. There are people saying even up to 10.
Is there any classification to know whether to do bypass or an endovascular procedure? Based on the imaging, you can classify into various classes. So based on that, you can plan the management.
Can you let us know the classes, please, doctor? What are those classes? I'm the faculty who asked the question. Can you give the answer, please?
Yes, so it's the task classification, transatlantic intersociety consensus.
Yeah.
It's divided into A, B, C, and D based on the level of lesion, and it's different for aortoiliac segments and femoropopliteal segments. So
yes,
based on the stenosis and the occlusion and the length of occlusion, it's divided into A, B, and C, A, B, C, and D, where A, B are mostly dealt with endovascular, and C and D are dealt with surgery. Now even C is more C also people are doing endovascular, but D will be usually very long length, and usually it will be involving the bifurcations. So there usually we go for surgery.
Thank you, doctor. That's something new I have learned from today.
Rajan, he
yeah,
is Dr. Sandeep, who's a vascular surgeon.
Yeah, I know, but that's a useful input to have. And the students, please note that there is a further classification available, some transatlantic kind of classification to assess which vessels can be stented and which patient limbs will need a bypass. So that's just know those details. You don't have to break it down into the various criteria, because that is more a vascular information. Right.
The only thing that I want to know as a surgeon is, can we angioplast and stent trifurcations, those vessels which are infrapopliteal?
Dr. Sandeep, can you give the answer?
Yes, sir. If it is a small, if the block is in the popliteal artery and involving the proximal branches, proximal anterior tibial and posterior tibial, usually they are not amenable for endovascular. So we need to do either mostly patient bypass in that setting. But even this patient had previously had popliteal artery occlusion, but because of his cardiac status, with history of previous MI, they had attempted a stenting. And usually we don't do stenting in the popliteal artery because of the knee flexion. The stent will break and occlude. So across the joint, we don't usually place stents, but this it was placed in the distal femoral and popliteal, and the stent is thrombosed.
There you go. So that tells you shouldn't do it, no?
Yes.
Anyway, right. What if you don't do any stenting for this patient? He refuses, he's not fit. What will you do? Is there any method that you can help the patient with? Doctor, the student?
So if a patient is not willing for, he can be offered anticoagulation, sir.
Anticoagulation?
Sir, yes, sir. if
Is
he
it
is not
anticoagulation or just blood thinners?
What about the foot, man? What about the foot?
Yes, sir. So a patient has an infected ulcer there, so he will require source control as well. So he will require definitely debridement with or without a TMP. This patient.
With or without?
Transmetatarsal amputations.
Please don't use short forms.
I'm sorry.
Yeah, we'll have to deal with the local lesion and hope for the best. But anticoagulation, I don't know. Doctor, is it anticoagulation or just blood thinners? Sandeep?
Sir, blood thinners, like both are like synonymous. We can give, patient was already on anticoagulation after the stenting. He was taking factor 10 inhibitors, but later on we stopped it. And for this patient, we have with the high risk, we had explained the attendants and the patient. So we have done a bypass, sir, and a transmetatarsal amputation. Now the wound is healing well.
Doctor, how did you take the consent for this patient? What all did you explain to him?
So in the case of this patient, sir, intraoperative, immediate postoperative, and further long-term complications we had explained. So in terms of intraoperative complications and immediate postoperative, so one is the possibility of anastomotic leaks. There are two anastomosis. Then two, the possibility of anastomotic stenosis, secondary anastomotic thrombosis has to be explained. Also, patient will require heparin infusions in the immediate postoperative period. So he has to be explained the risk of bleeding manifestations elsewhere, the possibility of a hemorrhagic cerebrovascular accident, the possibility of hematemesis amelina has to be explained.
Okay.
Patient also has to be explained about the possibility of graft thrombosis.
That's later on.
Yes, sir.
And basically, in terms of limb survival, are you going to guarantee limb survival?
No, that cannot be. That cannot be guaranteed.
So that is what you say. We are doing it in an attempt to save. It may not be successful. Also, you have to tell them the outcome could be adverse also as a result of surgery.
I think, in other words, femoral-popliteal segment and infrapopliteal segment, what is the patency rate? That is what you're supposed to tell the patient. You're doing a bypass. Is there a difference in the patency rate of bypass for femoral-popliteal and infrapopliteal? That's exactly what you're supposed to tell the patient. I mean, are you aware of the patency rates? 1 year, 3 year, 5 year patency rates?
No, sir.
Okay. I mean, our vascular surgeon Sandeep can tell us. Dr. Sandeep?
Yes, sir. So 65 to 70% for supragenicular and are just above 50% for infragenicular bypasses over 5 years.
Okay.
When we use vein, but prosthetics have a lower.
Okay, prosthetics cannot be used for infrapopliteal, right?
If there is no option, we can use, sir, but very low patency rate. It's around 35% for infrapopliteal.
So what is recommended is vein.
Vein.
Across the joint.
Across the joint.
Right. I think we've come through a fairly detailed discussion of the vascular case. Is there any questions? Nobody seems to be active on the chat box except me. Any questions, anything coming up from the students?
You're a fast finger, man. You're a fast finger expert.
No, all this is taken from my little book that I've written here. So I just have to do it. I'm trying
Dr.
to...
Ellen Mohan, sir, anything to say?
If there's nothing more, I think it was a good presentation. Doc, your theory levels are very good and you're confident in presenting, but be careful. You tend to say things which you can't justify. So be a little careful on how much of knowledge you share with your examiners, okay? When they ask for it, give it, but don't come out with things that are little beyond what the question is asked, okay? That's my only caution to you.
Thank you, sir.
Yeah.
Thank you,
Somebody asked. Yeah. Okay. Thank you, Dr. Hari.
Thank you, sir. I thank today's faculties, Dr. Chandra Sur and Dr. Dayananda Doli, and all our moderators. Dr. Shivatsa sir, Sheshagiri Rao sir, L.N. Mohan sir, and C.N. Rajan sir. So now we'll move on to the next session, that is Objective Skill Clinical Examination by Dr. Lakshman sir. Dr. Lakshman sir?
Yeah, thank you. Good evening. Give me a second. I'll share my screen. Can you see my presentation, please?
Yes, sir.
Can you hear me well?
Yes, sir.
Thank you. Good evening, ladies and gentlemen. I must first thank the SSB for giving me this opportunity to share some issues and knowledge about a relatively new way of examination called the Objective Structured Clinical Examination, OSCE for short. I say relatively new because the concept of OSCE has been around for a long time. In fact, since the late 1970s, literally 30-40 years old as the concept. But it took a long time for the concept to mature, and about 9 years ago, the Royal Colleges did most of their clinical examination, converted that into, at least in the MRCS, converted that into an OSCE. In fact, many of us who were examining were actually specially trained in the process in 2012 or 2013, I think. The DNB has adopted this over the last 3 to 4 years, and it came in very handy to the DNB people during the COVID time when everything was done online. And there is very serious thought that at least a part of the MS will be done through the OSCE in several of the medical universities to which these colleges are affiliated. So it becomes important for us to understand what OSCE is, how the questions are framed, and what are the advantages and disadvantages of the same. I have done this in 2 parts. One of them is to give you today, in the next 25 minutes or so, the basic principles underlying an OSCE examination. What is going on in the examiner's mind in the way the student is assessed. And tomorrow, for another 25-30 minutes, we will have the actual examples of the OSCE questions. And if we have more time, and if you are interested, we may start off with 1 or 2 OSCE questions today itself. We have a lot of questions in a bank with us. Now, the purpose of any examination is to assess what a student knows. Is it safe to let him free on the community, on the society, as a surgeon? That is the purpose of any examination in the discipline of surgery. And any examination has 3 uncontrolled variables. One of them is the student. What is it that he can do? The patient himself is very uncontrolled. We all know that, when you take an exam, when you take the history in a clinical examination, he tells you something, and when the examiner challenges you and asks the patient in your presence, he will tell you another thing, and so the patient is practically left dumbfounded. The student is left dumbfounded, and that is a variable which is very, very tricky. And the examiners themselves come in various sizes and shapes and attitudes, and it is nothing negative about it. It is just that people are very different in the way they examine students, their attitudes, the way they interact, the way they ask questions. Some of them may be very friendly but give you very little marks. Some of them may be very tough but give you a lot of marks. It's very variable. So in essence, what we have discovered, whatever I say here is, applies across the world. It's not just in India or in Karnataka. Across the world, there is a huge variation, and people felt that it is not fair. It's not a fair method of examination. And so the endeavor, the attempt is to have only one variable, that is the student. Okay, if the student is good, he'll get it. If he is not good, he will not get it. Can you control the patient and the examiners in such a way that this can be achieved. It is easier said than done, but that is the attempt. Now, if you want to control the patient and the examiner, you have to have standards and uniformity in the way you frame questions and the way you put it to the student. Now, you can control the aspect being examined. I'll tell you more about it. What is it that you're looking at? Are you looking at the interpretation of a test? Are you looking at communication skills? Are you looking at examination skills? Are you looking at the way the student does an operation, for example? That's number one. Number two, in terms of uniformity, you have to have the same degree of difficulty. So there must be some way in which the questions must be assessed and classified before the examination, not in the examination, mind you, where a certain percentage, it is generally accepted that you have 3 degrees of difficulty in the OSCE questions: the easy, the medium, and the difficult ones. And so each examination is structured in such a way that generally you have a third of each. Okay, 1/3 of easy questions, 1/3 of medium difficulty questions, and 1/3 of difficult questions. And these are objectively scored, so it's not something that is arbitrary. And it has to be uniform and repeatable. And this is again objectively measured before the questions are put to the students, because they have trial runs with people and repeated review by the examiners, and they make sure that there is no ambiguity in the answers that are expected, that are universally accepted. You find that many times examiners particularly have their favorite books, and they would expect that answer to be given. Now here in an OSCE, there are no favorites. There is a generally accepted thing across the whole set of examiners. They can't ask any other questions, and if a given answer is an expected answer is given, the examiner's individual favorite answer is not counted at all. And you have various aspects. It's time bound. For example, to me this is one of the best advantages of an OSCE. Everything is time bound. You have various stations. It may be 12, 15, 18, 20 stations depending on what you're doing. So you go from one chamber to the other, or you have one segment. If you're sitting in the same hall, one segment or the other. And what happens is that within that time you have to give the answer, and the examiner has to finish it in that time, so he cannot dilate on a certain issue. So he will have to ask you very limited questions. It's in fact very boring for the examiner, to be honest, but once you give a given answer or even a part of a given answer, he has to move on to the next one. So you have a wide coverage because you don't get stuck on one topic. For example, in a clinical examination, I have seen a patient, I've been in an examination, in a conventional examination, when, you won't believe this, we never went beyond gangrene. It was a peripheral vascular disease, and practically the student was grilled only on gangrene, and because he couldn't come out with quick answers, he never went beyond that. Whereas in this case, if you find that you don't have an answer for that particular topic, say for gangrene, the clock is ticking, and you lose that question, but you don't lose the exam. You then move on to another station with a different topic, so you never get stuck on one topic. So if wide coverage is there, and so you have a chance, if you don't know one aspect of the subject, you'll be offered other questions, and other aspects are examined, and you don't fail unless you are very poor in several aspects of surgery, and that is a fair enough result. But mind you, the ones in the yellow here are what I consider are the disadvantages, particularly for the examiner. It's a lot of work to set an OSCE question and to grade it about the difficulty, and then grade it as far as the repeatability and the uniformity is concerned. It's a lot of work if it's done in a scientific manner. The marking is very, very tedious because there are several aspects to an answer, and we are closely listening to what the student is saying. If he gets one of those, it's not just you give one total marks for a given station. There are five or six subdivisions, and each of those subdivisions has to be marked. And so it's something where the examiner has to be very, very, very attentive. Some people feel that it's not holistic. when you say something, it's all in bits and pieces. I am not very convinced that it is not holistic. I think it is a different way, and I think if the examiners get used to it, it can be made holistic, and that is left to the questions that are posed to the students. This is very true. If you have one exam and one hall and a few patients, you can get through a clinical examination. But for a proper OSCE, you need a lot more resources, a lot more stations, a lot more tables, a lot more space, and a lot more paraphernalia in terms of TVs, in terms of microscopes and whatever else you give. So it's a little tedious for in fact the examiners, and I do believe that once the examiners and the students get used to the concept, when it is new, there is a resistance. Once they get used to it, that they will be very happy doing it. Now, various aspects of the clinical examination can be tested. It can be history taking, it can be physical examination, it can be interpretation of tests, use of instruments, procedures, and communication, soft skills like communication, conveying bad news, things like that. Plenty of options are there, and all these aspects can be examined, and usually in a typical OSCE exam for a final year MS or DNB, there will be a mix of all these that are given to the students. The actual practical examples of these things I will discuss in the mock test or on the questions that we're going to discuss tomorrow. As I said, there are many stations for the OSCE, which means that your fate does not lie among 4 examiners. Most of the time it's 4 people who examine you in a clinical examination. Here, if you have 15 stations, you may have 15 examiners. So there is no bias. If 1 or 2 people who don't like you cannot fail you. That's as simple as it. It's a huge advantage as far as I am concerned. So you go from one station to another, and you may lose 1 or 2 stations, but if you do well in the other stations, you can just sail through the examination. I have already mentioned about wider coverage. While people may think that wider coverage makes you read a lot more, that is the whole idea. We need you to be having a wide knowledge about the science of surgery. Also look at it in the positive sense. You have more chances. As I said, if you don't know about gangrene, you may go elsewhere and do very well about pancreas or the breast or the thyroid or whatever. So you have more chances. And this is a very interesting thing. What is not very common in India but very common in Western examination, OSCE examinations, is standardized patients. You actually have actors. They are actual actors. They come there, they are trained in telling a proper history, in a way giving a proper response to the questions that are asked by the examinee, and they don't fool around. They are paid for that work, and so they give you proper answers, and they are also trained to mislead you. So there is a standardization in which they mislead you, and the examiner is checking whether if you're misled at all, but even if you are, whether you have the capacity to come back and ask the right set of questions to get the answers that you want. And there are standardized checklists for answers. This is a very interesting aspect of OSCE. For example, if you're examining a patient with a peripheral vascular disease, they put you there, the examiner says nothing. He just says, look, this is a case of peripheral vascular disease, kindly do an examination. That's all. So they'll just check whether you are looking at all the pulsations on both sides. We are looking at the chronic ischemic changes of the skin, and then we also ask you, as you are doing it, walk me through it, talk me through it. So you're supposed to be explaining what you're doing and why you're doing it, and you have a set of 5 or 6 standard answers that we expect. Very standard answers. Nothing, no detailed names of tests and things like that. Standard answers where you would do in a clinic, in a surgical clinic. So if you do that, if you get those answers, the job is done. They keep ticking. Yeah, he looked at both bilaterally. He looked at his popliteals properly. He looked at radials. He looked for skin changes. Keep ticking, and when they do it, you get it. If you miss any of that, they may prompt you or they may not prompt you. As I said, it is time bound. And this is extremely interesting. In an OSCE examination, you have practically no interruptions. You understand? So you really are allowed to do everything, and only when you don't get some certain important things at the end of your reporting, at the end of what you have done, you are generally prompted. if at all. And so you get a chance to have a good flow of your thoughts, and so it does help you to, channelize your thoughts and do things in a methodical way. And if somebody wants to check your psychomotor skills, that is your practical skills, they may give you a mannequin and and then ask you to put a suture somewhere, close an abdomen and things like that. And they'll look at what are the things that you're doing, again 5 or 6 points, and then they'll decide whether it is done properly or not. There are many types of questions. As I said, you can have a picture and you're supposed to identify that picture, and following that identification you'll be asked 4 or 5 questions on the picture that's given to you. Many times, if you're very smart, by looking at all the questions that are asked, you can get a fair idea of what the specimen is. But sometimes, unfortunately, that's one of the disadvantages of this. If you don't get your first identification correct, you will lose the whole station. But mind you, it's not the end of the world, because you can afford to use 2 or 3 or 4 stations and still come through. It may be the still picture is what I meant there. It can be a video paper, it can be a video, and then they show you an operative video and say, what would you do next? Or what do you think is happening? If there is a complication, how do you think you could have avoided it? Those kinds of questions that are asked. And if you have worked in your wards and attended all the operative sessions, most of the time they'll be very straightforward questions. They will not be very unusual questions like one would ask in a quiz, for example, where it's fun learning, it's important to know, but in a standard final exam they would not be asking any tricky questions. Procedures can also be tested. It may be only one aspect of a clinical examination. We all know that there are several aspects to a clinical examination, like history taking, physical examination, interpretation of tests, interpretation of images. It could be a CT image, a plain X-ray, an MRI. Generally they don't ask ultrasound unless it is very, very obvious, like a post-acoustic shadow of a gallstone and things like that. And they can ask for description of performing procedures, bedside procedures. It could be introduction of a central line catheter. It could be as simple as a dressing of a wound. Even that may be asked, and obvious operative procedures can also be asked. Now, these stations that I talked about have various ways in which you can be examined. There may be an examiner sitting there. There may be even 2 of them, just silent observers. As I told you, it usually in clinical examination there will be a patient, and they'll tell you, examine this patient's peripheral vascular. This is a patient with a PVD. Kindly undertake an appropriate examination. That will be your station. So they'll sit there and they're just watching you. Sometimes it can be unnerving because you're used to somebody talking to you all the time and jumping on you, and you go there and nothing is said or done by these examiners. It can be a little unnerving, but they're there to help you, and then they may or may not give you prompts. And the questions that are asked may be just written there. You'll have an answer sheet for each station, and they may just ask you 4 questions, 1, 2, 3, 4, 5, and then you just have to write the answers. Or the examiners may ask you those questions, and they will do the marking once you give them the answer. And there are, as I said, many types of answers that are expected. And please, for every exam, before you go in, make sure that there is no negative marking. Okay, if there is a negative marking, you have to be careful. I personally believe that there should be no negative marking. I think you must. Medicine is, there are certain uncertain things in medicine. Even as after 35 years of practice, I am uncertain about certain things, in my clinical judgment. And so I always feel that the student must be given an opportunity to have a calculated guess, but that's not a universally accepted phenomenon. So there will be exams where there is a negative marking. If that is the case, be careful. And as I told you, there can also be unmanned stations. So you just walk into an empty room, you just watch a video that is there, they'll give you instructions there, watch a video, see a picture, there are a few questions, you answer them and get going. There may be no examiners there at all. The only thing is a timekeeper they'll probably give you 5 minutes for one station, and then the bell rings and you're expected to leave the room at that time. So you can have manned and unmanned stations. Now we come to the interesting part of scoring, and this is where I believe OSCE is very, very structured and very, very objective. you will see that in the examination part, however smart the examiner is and whatever effort he has made to make it very objective, it's a little difficult. I've set OSCE questions and I have gone through it, but the marking can be very, very standardized. You can say each of these questions have this much marks. That is what is decided by the examiner or the university. It can be manual or electronic. That's just computation. That's not very important. But it can have a uniform marking for each of those questions in the whole exam, or it may be weighted. In fact, most OSCE stations are weighted. When it is determined that we are posing a difficult question to you, it will have higher marks. The easy questions will have lower marks. The other interesting aspect of OSCE is how does one decide what the passing mark is. Most people will have a mark like any other conventional exam, 50%, 60%, 65% marks you should have had. Okay, that is the commonest. But a lot more involved in calculations. Of course, all these are fed into computers and the algorithms give you the marks nowadays. The first and the last one that I have mentioned here. One is a relative scoring, where they look at the mean score of that given batch. Mind you, it's not, suppose there are 50 people taking an exam, then each time the examination is given, then they get the mean, and if you are within 1 SD of that mean, 1 standard deviation of that mean, you will get a pass. If you go beyond that, you will fail. Okay, that is the kind of one other method that they use. The Angoff method is a lot more interesting and challenging. The same examination is given to the examiners, and obviously they don't get 100% right. They may actually get 7 or 70 or 80% right, and then they say, okay, if the examiner gets 80% right, the student must be allowed to have 20% less. So if you get 60%, you will pass. So these are the kinds of, but it depends on the university and the person who is setting up the exam. Any of these methods can be used. Now, we have talked about the ethos, the theory behind it. The actual point is does it really work? And there are many papers. What I have shown here are a few representative papers. It's by no means very comprehensive because of time constraints. I didn't want to go into great detail. But here is a paper which had 52 students and 22 examiners. Okay, there was general satisfaction across the board. The majority liked it. They liked the validity and the reliability of these things, and they found it to be much more comfortable compared to a conventional examination. But the students definitely expressed increased stress. And what were the reasons for the stress? The same points that I said is an advantage to a student, okay, which is a wide coverage of the subject, was perceived as a disadvantage by the students. I find it very, very interesting because they take their chances. I think what it means is that they take their chances. They read certain part of the text or understand certain parts of the surgical knowledge. They take their exam, and then if that is asked and if they get it, they get it. If something else out of the box is asked, they fail. They are happy with that situation, which I personally disagree with. I think you should have a very wide knowledge about the subject, and obviously there is a disagreement between what I personally feel and what the students feel. Less time available, actually it's not too bad at all. Most of the time it's because they're not used to the examination. So once they get used to it, it will be quite useful. Attitude of examiners. Now, this is something again a matter of getting used to, because they're so used to talking so much on either side. Both the examiners and the students talk so much that when an examiner is sitting there doing nothing, the students feel very, very uncomfortable, and higher expectation to pass somehow. And in fact, my students of the last 2 years who wrote the DNB, they cleared everything there, and somehow they feel that it's probably true also. that they should get a higher percentage of pass marks, higher percentage of passes in the OSCE type compared to conventional type. And so there is a higher expectation to pass, and if that doesn't come through, then they will have a stress because of that may not happen. Very few people also complained of increased difficulty. This is about the students, but as I said, this would not necessarily be true, because these questions, if the OSCE is designed properly, are weighted, or they're actually classified and given properly. What do the examiners think? Some of them feel that it doesn't actually reflect the competence of the student, but it's a minority of examiners, it's not a majority. And some of them feel that it is not holistic, that it doesn't actually examine all aspects. It's a point of view, but the issue is that if, as an examiner, you make the questions holistic, the answers that you get will also be equally holistic. Now, people have measured the fairness in an OSCE examination as well. How do you measure the fairness? The same examination is given to a similar set of people who have also performed in a conventional examination, and they have seen which is more representative. The standardization of stations are generally very effective. That is obvious. You can say you have this set of a given standard picture or a video and a set of questions. Nobody can ask anything outside that, and so that would be fine. Very interestingly, inter-rater differences are significant, even in an OSCE. Even when there are set questions and expected answers. Where does that come? There's one examiner who may say that if he gives me something near what is expected, I'll give him the marks. The other person may say he has to give exactly what is expected. That is where the inter-examiner differences crop up. And so what is done to correct this is that all the examiners are given a dry run, as it were, are given a whole course, for example, and say, look, these are the things that we would like you to do. And so to some extent that will reduce the inter-rater difference. Recommended standardization of patients is also extremely important. Okay, I just kept a little alarm, and that's what went going.
Your time for another 10 minutes.
Yeah, and the training of raters is also very, very important. And this is something which I think we have to take on a very big scale. As I said, the role of the examiner is very, very important here. Particularly not at the time of the examination. In a conventional examination, the examiners play a a very important role in actually asking the questions and helping the student, whatever else, and then marking and all that. But in an OSCE, the whole thing is a little more impersonal. That's what makes it objective. That's what makes it a lot more fair, I believe. And the training for that has to be done. Without training, you cannot really just straight away jump into it's like jumping into the deep end of a swimming pool without learning swimming. I'm talking about the examiners. So the examiners also need training. In the Royal College, for example, we were given a 3-day training in 2013, I think, or 2012, before we were let free on the students. The domains tested, it can be both knowledge and skill. Please understand, surgery is a skill-based training, so if you just get knowledge, it's not important. So pathology, critical care, clinical skills, procedural skills, even ask about ethics and professionalism, even that can be done. And I'll give you examples of this tomorrow when I do that. And so I end here. I deliberately ended about 5 minutes earlier than the given time to make sure that I can take some questions, and more importantly, we have many senior surgeons in the audience. I would like their comments and their and questions, if any, please. I am looking at the chat box. Dr. Nooli says negative marking should be abandoned, at least in medical education. All right, I mean, I have at least one person agreeing with me, which is very nice. Sir, are there any dominant examiners? There is no dominance. As I said, in a typical OSCE, particularly in the Royal College, there are 15 stations or 16 stations. And so there is no question of any dominance. And your dominance is only for 1/16 of
that's a different...
Sorry? Okay, I think Harish was, talking something, So this is the big advantage of OSCE. See, one or two people cannot decide your fate. That is a very important thing. And so you can be very comfortable when you go about, but there is no question of dominance.
Dr. Lakshman, very nice presentation. Is there a difference in the OSCE settings of the DNB versus the Royal Colleges?
There is a big difference, yes.
The number of stations are the same, but the number of examiners are much less, right?
Correct. There is a big difference, and that is something that has to be addressed. And honestly, they're doing a very fair attempt of giving an OSCE, and even if the examiners are fewer, the answers will be standardized, and so
the correction is done by
the examiners.
Okay.
Yeah.
I always felt enamored by OSCEs, and in the 2014-15 early days when it first came in, I had already made OSCE sets and had shared it with the students at Martha's. I'm happy that it has come out now and is going to be the method of evaluation, and a more uniform, widespread of knowledge can be assessed. Yes, ma'am.
Srivatsa, you have any comments to make?
Yeah, it seems to be a good one as compared to conventional examination. And it is, as you said, standardized, fair. As you said, the students might have more stress levels, and probably it will take more number of examiners.
It does.
Plenty of stations.
Yes.
So that may be a big negative factor, given the fact that nowadays examiners don't want to, there are not very many examiners who are willing to come and become examiners. Teachers who are willing to become examiners.
Yeah, that may be a practical problem, but as I said,
youngsters, yes, there are so many youngsters now. So if you include assistant professors and associate professors, you will have the sufficient number.
Yeah. The other thing is, as I said, you can have stations without examiners.
Okay, yeah, that's good.
You can actually design. It's very versatile. You can, and then it's like, even though it's a clinical examination, it is like examining your theory paper. You can design the questions and the expected answers in such a way that if the person has done everything that he has to do, has mentioned everything, then the job is done.
Yeah, psychomotor skills included would be good. If there are stations for psychomotor skills,
yes,
that's also good.
Yeah, an actual clinical examination or a history taking station needs examiners and assessment of a psychomotor skill, for example, suturing, a model of suturing or whatever. Those things need examiners. But if you're looking at the interpretation of an X-ray, interpretation of a slide, interpretation of blood gases, for example, you don't need an examiner. You just leave it there and give a small short clinical history, give the actual data, and then you can ask a few questions, and those things, the answers from those stations can be taken and corrected by anybody. It could even be corrected by,
Yes, true.
Even the juniors in the team.
It's an assessment of the wide knowledge. That's good.
Yeah.
Not just confined to clinical examination and diagnosis.
Correct. Many times in a conventional clinical examination, discussion doesn't go beyond the history and clinical examination. Nothing much is asked about investigations and treatment. Many times we have found that cannot happen here, because they will be perforce. There are stations which actually ask them to interpret the actual thing. That's another very nice thing about OSCE. They don't make up those data. They'll take it from a patient and put it there. You know, an MRI from a patient, blood gas from a patient, electrolyte abnormalities. Those are things which are very nice about OSCEs.
Yeah.
So
What will
number
be
of
the duration, time duration? Let's say we have 6 students or 8 students taking the examination. What will be the amount of time which will be necessary to complete the examination?
It depends on the number of stations. Usually they give you 5 minutes per station.
Okay, then it is quick.
It's quite quick. It's not, you can have 2 sets of patients in one day, of students in one day. And if you have many stations, which is difficult to do, it occupies space and a lot of effort from the examiners, you can have 2 sets of students going each session. You have 2 sets of students in the morning and 2 sets of students in the afternoon, so you can examine a lot of people. I'm talking about the the MRCS experience that I've had. It can be very big compared, depending on the number of students who are coming.
Okay, and the scoring, when does the scoring take place?
It happens then and there. Once immediately it happens, and at the end of the session, all the answer sheets from all the stations are collated, and a clerk does the totaling. Actually, one of the office staff does the totaling, and very interestingly, when they have these marks in the Royal College, I don't know about DNB, but in the Royal College there are only 4 sets of marks. Either you are a severe fail, marginal pass, or a good pass. Only 4 things. And so if there are people who are in marginal fails, and then the examiners sit together and then say, look, this guy was reasonable, but there is a little discussion before you actually declare them as fails.
Okay. Yeah. Okay. And maybe a good system to be introduced at the undergraduate level to begin with.
It would be.
The only thing is the numbers of undergraduate students. Numbers are too huge.
Yeah.
So I do not know how many days it will take to complete the examination. That may be an issue.
Yeah, that's true. But as I said, it can be worked out in a given situation.
An undergraduate student. Assessment of an undergraduate student. And later on, we can extend it to the postgraduate.
Correct.
Sir, number of stations, how it is defined? How many stations we have to?
There is no definition for that, but it depends on how wide you want your examination to be. All right. So it depends on the examination. If you think that it is a final year DNB where you want a very wide, canvas to be covered, maybe you want 20 stations.
That is decided by the examiners.
Examiners and the university, yes. Yes.
See, the NMC has ideas of having an exit examination. They are looking at theoretical knowledge, like a theory question paper. I think if they do it OSCE way, maybe it is better than just asking them to do exit examination based on theory.
NMC has, I don't know its view on OSCE, but NMC has come out with some very nice concepts in the last year. I have been very impressed, and the training and the recommended training is really holistic. There is no doubt about it. Yeah.
So that was good listening to you, Lakshman.
Thank you.
It was.
Thank you.
Yeah.
Thank you, Dr. Lakshman, sir.
Thank you very much. Thank you.
Very elaborative discussion on OSCE. So we'll continue tomorrow also with the part 2. Yeah, now the most important aspect for the exam going PGCs. So radiology, there will be a status of radiology discussion for the examination. So as you all know, we will discuss about the X-rays, the varieties of chest X-rays, X-ray abdomen, barium swallow, barium meal, and some invertograms, will be kept in the examination. I think in your respective medical college, those X-rays will be available and we will have a discussion. The only untouched area is CT scan. So now let's have a very depth discussion about the CT scan with our renowned radiologist, Dr. Sandeep from Prima Diagnostics. So I welcome Dr. Sandeep. Dr. Sandeep?
Yes, sir.
Yeah. You can proceed with your slides presentation.
Okay. Good evening, everyone. My name is Dr. Sandeep GSK, working with Prima Diagnostic Center. I'll be discussing some radiology cases which we see on a day-to-day practice. Now, in recent times, CT has become the modality of choice for especially abdominal pathologies, and other than X-rays and ultrasound. So I'll be telling you in brief a little bit about the anatomy also, and how to look into read a CT scan. So basically, when we read a CT, we should always see a CT scan in two planes. One is axial and another maybe a coronal or a sagittal. Fine. And knowing the anatomy is very, very important. Otherwise, it's difficult to interpret CT images. Fine. So coming to case number 1. So clinical history.
Sandeep, can you share your screen? Dr. Sharath, can you share your slides, please? Sharath, is the slides are visible?
No, sir. Sandeep sir has to share his screen. Sir, have you shared your screen?
Sandeep, you please share your screen. Yeah, please take your time. Yeah, we can see the, just click on the first line. Yeah, make it full screen, Dr. Sandeep.
Is it visible now?
Yes, yes, is it visible? Please proceed, Doctor.
So coming to case number 1, clinical history. A 39-year-old man presented with a 2 days history of central abdominal pain, which had subsequently localized to right iliac fossa. Then clinically, he had localized guarding, rigidity, and rebound tenderness in the right iliac fossa. The patient was sent for an ultrasound, and which showed an right iliac fossa collection, and which needed further evaluation. So the patient came for a CT scan. So now once on an ultrasound, we see right iliac fossa collection. The differentials, what we should think of is either an appendicular abscess, a mucocele, appendicular mass with abscess, maybe a cecal diverticulitis. And in case of females, a tubo-ovarian abscess is one differential possibility which we should think of whenever we are looking for a right iliac fossa collection. So I think video.
Yeah, video is not able to play the video.
Yeah, not able to play the video.
Yeah, Nishant.
Shall I share my screen?
Yeah, please, Nishant.
Yeah.
Is my screen visible, sir?
Yes, video 1. Yeah. Dr. Sandeep, you can
coronal images. Fine. So in coronal images, you can see there is a collection
fine, with a lot of air pockets. This is the collection which we are seeing, and this is cecum, and just posterior to the cecum, that is in the retroiliac region. Can you play the second video? This is these are sagittal sections, and you can see this is the cecum ascending colon, and there's a thick walled collection which is sitting in the retrocecal region. Fine, there's a lot of fat stranding surrounding the collection. Third. No, there's a different one. I think I can just close this. Yeah. Next slide. Yeah. So this is an axial section where you can see the cecum out here, and there's a large collection, thick walled collection with an air fluid level. This hypodense, what we see is air, fine, and this is an air fluid level located in the retrocecal region, and appendix was not seen separate from the collection. Next slide. So CT findings was that of a very thickened appendicular base, which was seen to communicate with a large thick walled collection, and there was an air fluid level in the retrocecal region. There was a lot of surrounding fat stranding and localized anterior peritoneal and retroperitoneal facial thickening. There was no leak of positive oral contrast into the collection, and there were some ancillary findings like secondary inflammatory wall thickening of cecum and proximal ascending colon. So the diagnosis was acute perforated appendix with an periappendicular abscess. Next. This is case number 2. So clinical history was patient was a case of prostatic cancer on treatment. So he came with sudden onset upper abdominal discomfort to the emergency department. Next. So this is a coronal image of the thorax and the upper abdomen. And in this, you can see there is a large defect in the diaphragm in the region of esophageal hiatus. And there is significant herniation of the stomach mesenteric fat into the thorax through this diaphragmatic defect. You can see there's a large defect. This is the diaphragm, left diaphragm. This is liver out here, and there's a large defect out here, and there is herniation you can see into the thorax. And what you see, this black out here, is the herniated stomach. Next. This is another section where you can see the stomach filled with oral contrast. Positive oral contrast is seen within the stomach, and the greater curvature is seen above as compared to the lesser curvature, which is seen below. Next. So to summarize the CT findings, there was a large diaphragmatic defect in the region of esophageal hiatus, and stomach was located entirely in the intrathoracic region. And a part of mid-transverse colon and mesenteric fat was also seen herniating. And the greater curvature of stomach was seen above the level of above the lesser curvature. There were no features of obstruction as such. Oral contrast was seen coursing normally. So the diagnosis was a large diaphragmatic hernia with an organoaxial type of gastric volvulus. So gastric volvulus is basically a twisting of all or part of the stomach more than 180 degrees. It is a type of closed loop obstruction. Okay, and then there are 3 types which we need to know. One is an organoaxial, mesentericoaxial, and a combined organo and mesentericoaxial. And this is just a representative image to show how to differentiate between an organoaxial and a mesentericoaxial type of a volvulus, where in the organoaxial volvulus, the rotation of stomach happens along the long axis. So the antrum rotates superiorly and the fundus rotates posterior-inferiorly, and the gastric greater curvature goes above and the lesser curvature comes below. Fine. In mesenterico-axial volvulus, the stomach twisting happens along the short axis of the stomach, and so that the antrum of the stomach is displaced above the gastroesophageal junction. Next. This case number 3, clinical history, a 55-year-old female. She came with intermittent episodes of abdominal pain, nausea, and vomiting. So ultrasound was done. It came as normal, except cholelithiasis was there. Lab tests, there were raised leukocyte count. So a clinical suspicion of cholecystitis was made and sent for further evaluation for a CT scan. So these are the axial images where you can see there's a lot of inflammation in the mid-abdomen. Can you play the video again? Can you stop? Yeah. So here you can see there's a small outpouching arising somewhere from the distal jejunum, and there's some small fluid level within that outpouching. Continue. Yeah, this is the outpouching. There's another outpouching out here arising from proximal ileum. Next. So this is the mesenteric edema which I was talking about, which looks very hazy as compared to the normal fat, which should look black. So this is looking very hazy. There are prominent vasa recta which are seen, and there's a small outpouching which is seen arising from the proximal ileum. Next image. So this is another axial section at the level of kidneys. So you can see one outpouching. This is distal jejunum, right? And there is an outpouching out here. There's some inflammation surrounding it. Next. To summarize CT findings, so there are some few fluid-filled outpouchings, likely diverticuli, arising from distal jejunum proximal ileum located in the mid-abdomen, and there was a lot of surrounding mesenteric edema, fluid, and prominent vasa recta. So, and there were some few regional mesenteric lymph nodes also which were enlarged. So the diagnosis was jejuno-ileal diverticulitis. So jejuno-ileal diverticulitis is just an acute inflammation of diverticula of the jejunum or the ileum, and it is a much rarer condition as compared to colonic diverticulitis. Next. So coming to case number 4, clinical history. A 52-year-old male presented with lower abdominal pain, fever, and there were pus cells in urine. So clinically, the clinician felt it was cystitis, and the patient had a past history of left iliac bone TB osteomyelitis with an abdominal wall abscess, which was treated almost around 5 to 10 years back. And he came with the similar type of an abdominal pain in the lower aspect. So an ultrasound was done, which showed some bowel thickening in the left iliac fossa. So these are coronal images where you can see the positive oral contrast, which is opacifying the bowel loops. There is some wall thickening, and there are some few air pockets which are seen outside, and there's a small loculated collection which is seen along the wall of the bowel. This is located in the left iliac fossa. There is some surrounding fat inflammation is there. Next slide. So these are axial images. You can see some inflammation of the fat. There is some wall thickening, which is involving mid-sigmoid colon. There is a small loculated collection intramural in the left lateral wall of mid-sigmoid. Can you play? Yeah. And there is mild thickening of the adjacent urinary bladder wall. This is the thickening of the bladder wall. This is mid-sigmoid colon. There is some wall thickening, eccentric wall thickening. There's a loculated collection. There are some tiny dots of air pockets. And there are some few outpouchings seen in this region, tiny contrast-filled outpouchings. This is another outpouching. So these were all small diverticula. So this is the axial image where you can see there is a localized wall thickening, and there is a loculated small collection in the intramural wall, and there are some tiny air pockets. So next slide. To summarize CT findings, there was asymmetric wall thickening with mucosal folds prominent in the mid-sigmoid colon, and there were some few diverticuli arising from the mid-sigmoid. And there was a small loculated collection, most likely an abscess with some tiny air pockets. And there was a lot of pericolic fat stranding and some very tiny pericolic lymph nodes, and there was localized peritoneal thickening, right? And there was secondary localized cystitis. So the diagnosis was often acute sigmoid diverticulitis with a diverticular abscess and probably some contained perforation also, since some few air pockets were seen in the intramural wall. Next case. And this is a 11-year-old girl who presented with acute onset abdominal pain, nausea, and vomiting since 3 days. So this is a supine abdominal radiograph, and this is an upright abdominal radiograph. You can see in the supine radiograph there are multiple dilated small bowel loops in the mid-abdomen. And in the upright radiograph, you can see multiple small air fluid levels. There are multiple small air fluid levels in the mid-abdomen. There's no definite gas shadows in the peripheral aspect. So that means there was no gas in the colon. There is no gas in the region of rectum in the pelvis. So only some small air fluid levels are seen in the mid-bowel, mid-abdomen. So most likely it could be a small bowel obstruction. So X-ray shows multiple dilated small bowel loops in the upper and mid-abdomen, and there was no gas in the colon or rectum. There were no features of pneumoperitoneum also. There was no air seen underneath the diaphragm or in between the bowel loops for me to tell it as pneumoperitoneum. So differentials to consider was a small bowel obstruction, and since a young girl could be a midgut volvulus or an intussusception also. So these are axial images of the lower abdomen and pelvis, and you can see there is a small bowel dilatation, and there is some heterogeneous dirty shadow-like region in the small bowel. So these are all dilated bowel loops. Whatever you are seeing, there is some abnormal and mucosal surface and serosal surface enhancement. Multiple dilated small bowel loops. There are multiple lymph nodes and some mesenteric fat stranding and prominent vasa recti is seen. So this is a coronal image where you can see multiple dilated small bowel loops. Here you can see there is a very heterogeneous dirty area, something looking like a fecal matter, and there are a lot of air pockets, black dirty air pockets within that. Similar kind of a lesion is seen here also, And this also looks very black and dirty. So this is the dirty focal lesion which I was talking about in the small bowel. Next slide. And this is another lesion which is sitting in the small bowel. So these are the coronal images where you can see there are multiple dilated bowel loops, and this dirty shadow material is sitting in the small bowel, somewhere in the proximal or mid-ileum. To summarize CT findings, multiple dilated small bowel loops with air fluid levels showing some diffuse inflammatory wall thickening and enhancement. Next. Yeah. And there are two discrete focal areas of some semi-solid kind of a material with some internal interweaving dirty shadow air density. There were two lesions, one of them located in the distal jejunum and another one in the proximal ileum. And there was mild ascites. So diagnosis was small bowel obstruction by a trichobezoar. Bezoars are nothing but just some accumulations of indigestible material within the gastrointestinal tract. So this was one bezoar, trichobezoar, and this was another one which was causing obstruction. Thank you.
Yeah, thank you, Dr. Sandeep. So it's a in-depth discussion about the CT scan. You made it actually. With your precious time, you spared us for all the your busy schedule to Surgical Society Bangalore. We are so grateful on behalf of Surgical Society Bangalore, Dr. Sandeep. Thank you. Thank you, Dr. Nishant.
Any questions? Anyone?
Any questions from postgraduates?
Hello.
Yeah,
yes.
please.
Sir, after the CT, why there is so much delay for the reporting by the radiologist?
So why there is so much of delay in reporting?
Delay, because now, for example, I'm suspecting a perforation. I would like to go for surgery at the earliest. But there's so much delay sometimes they take because we are at the remote areas and the radiologist is at either.
Sir, what basically happens is that there'll be a lot of patients. So we'll be interpreting almost 30 to 40 scans in a day. So maybe I think that may be one of the reasons, because interpretation and then, writing a report and then giving it for typing and then, all that process takes a little long time.
Emergency, sir?
But usually I think when it is an emergency case, the oral report is usually immediately given. And the written report takes a little longer time to come.
And next thing is about renal parameters, sir. If little creatinine is high, then some people they say don't give contrast. Is it true?
Yes, sir. So what happens is that because these are all contrast which gets excreted through the kidneys. So what happens is if the patient's serum creatinine is very high and we give contrast, the patient goes into an acute renal shutdown sometimes. So and then it becomes very difficult to manage those type of patients. So as a general protocol, we see to it that every center or hospital will have a guideline where they will limit the serum creatinine to some particular level, and then beyond that, only under the guidance of a nephrologist, or if can be avoided, contrast is avoided.
Okay, sir. Thank you.
Any other questions?
Sir, can I ask, sir?
Yeah.
Just for the benefit of postgraduates, sir, can you please elaborate what is the preparation for a contrast enhanced CT? Because if we need for an emergency, do we need to keep, how long we need to keep them NPO?
So basically, if it is an emergency scan and you're suspecting something appendicular or some cholecystitis or something like that, there is no protocol where you have to keep the patient NPO or anything, nothing like that. You can immediately shift the patient. But otherwise, on a general basis, a minimum 4 to 6 hours of fasting is required. Otherwise, there is not much need of fasting. And basic preparation, if it is a routine case, we usually give them some laxatives or Dulcolax or something to maintain a clean bowel, so that we do not get confused with fecal matter. Once lot of fecal matter is there in the images, it becomes a little difficult to interpret. So that is why we need a clean bowel. But otherwise, if it's an emergency, then there's nothing required. It can be done immediately.
Then what is the role of NPO status for CECT abdomen, sir?
So basically, the problem is sometimes, the patient has got solid food and he comes, if he vomits, patient is lying down, the patient can aspirate also, right? So that fear is always there. So we don't want
the contrast.
The solid material, whatever they have just immediately had their food, the stomach is full. If the stomach is empty, then there is no issue. Right? If it is there in the small bowel, it's not a big deal. But in the stomach, usually we prefer, somebody has taken solid food, they may aspirate, and then it becomes difficult because the patient cannot get up. So he vomits and he aspirates his own vomit into the trachea.
Yes, sir. And sir, if I can just put in a point regarding what Dr. Dayanand sir was telling about the delay in the radiology reports.
Right.
What we do is, if there is a patient who needs an emergency scan, we directly call up the radiologist, tell them this patient is coming, we give them the history. And like if we are suspecting appendicitis, we tell him, you just look at the appendix, tell me what the status is. So we don't ask for a detailed report of through and through. So probably that can be done for certain and prioritize particular patients for emergency. Otherwise, we don't keep disturbing them over the phone.
Right.
Sir, how often you people give videos?
The patients. They give a CD error, sir.
No, they give usually film with report. They give video also?
Yes, sir. In a CD we get.
So usually CDs are given, and that CD can be, it's not a video, but those CD images you can scroll up and down.
Like films only.
Somebody has asked regarding jejunal-ileal diverticulitis is a rare condition to be considered. Can DD of multiple GIST can be there? Basically, whatever diverticuli were there, they were all non-enhancing, and there was fluid level within them, and it was clearly there was no associated solid component for me to tell that they could be multiple GIST. Right? So GIST did not come as a possibility at all.
Sir, with respect to Dayanand sir's question, sir, in the films, I think they are limited to only some 20 or 30 images, but in the CD, you will get the entire range of images, whatever sections they have taken. Like if they've taken 100, all 100 will be there in the CD. So while you're scrolling, it'll almost be looking like as if you're going through a video.
Yes, sir. Thank you.
Right. So what we do is that there are, we take thick images and then we recon it to very thin images. So basic interpretation a radiologist never does on a thick images. He always done it on a reconstructed thin images, and those reconstructed thin images can be put only in the CD and given, so that you can scroll it and look into the pathology.
So if there are no questions, once again I thank Dr. Sandeep.
Thank you, sir.
So solving the practical aspects of radiology. Thank you. We come to the end of the today's program. On behalf of Surgical Society Bangalore, I thank today's faculties, Dr. Dayanand sir. So you are there the whole program. Thank you, sir. So Dr. Narayan Chandra Etsu, just he went for the emergency surgery in the halfway. I thank all our today moderators. So tomorrow Alexa, tomorrow we are starting the program at 5 o'clock with the 3 cases. Followed that, there will be a OSCE part 2. Then there is a discussion on surgical specimen, like pathology surgical specimen for postgraduates. I think this will be a useful program. Please do log in at 5 o'clock. Thank you all and all. Good night.
Good night.
Good night, everybody. Good night, Rish.
Thank you, sir.
Okay.